वेरी गुड यार, आवाज़ मतलब हाथ पेन हो रहे कि नहीं हो रहे, दर्द हो रहा है कि नहीं हो रहा है? हाँ, तो કોણે કીધી આટલી મહેનત કરવાની? ઓલા થોડી કીધું વગાડો જોર જોરથી. हाँ, बाद में देखते हैं सर. हाँ, उज्जवल ने बोला नहीं था ना कि जोर जोर से मारो. उसको किसको पता आपके ड्रम का आवाज आ रहा है कि नहीं आ रहा है? आपको भी नहीं सुना दे रहा था. Great. We'll start in next 5 minutes. So before that, we'd like to thank all our supporters who have supported this last beautiful 3 days conference, including first day with Imagica. And like to thank, hope you all enjoyed Drum Circle. Yeah. So we'd like to thank our Pulse as our core supporter for supporting a Drum Circle. And oh party, आगे आ जाओ. जिमी मैम आने जाओ, આવી જવાનું. હા, હવે તો બધાને આદત પડી ગઈ ને, રૂજો ટાર્ગેટ કરો કાલે હું પણ ટાર્ગેટ કરીશ બધાને ટર્ન બાય ટર્ન. અરે એટલે માઇક નહીં લેતા હું, સમજા સમજા मैं माइक क्यों नहीं लेता हूँ आपको. ओके, सो होप यू ऑल हैव पैक्ड योर बैग्स एंड लॉबी में रख दिए. किसी के बैग्स है रूम के अंदर तो नमन सर को बोलता कि वहाँ से कलेक्ट करवा ले. राइट, सो सेम द वे वी केम, हमको लगेज फिर से बस में डालना है. बस वहीं पे हमको मिलेगा जहाँ पे हमने उसको ड्रॉप किया था. सो जस्ट मेक श्योर कि आप अपना लगेज यहाँ से कलेक्ट कर रहे हो, बिकॉज अभी हमने सबने लगेज वहीं पे डंप किया हुआ है. तो काइंडली जस्ट मेक श्योर कि आपका लगेज वहाँ से बस में आ रहा है. एंड वी हैव टू मूव आउट फ्रॉम हियर बाय 2:30, अदरवाइज रात को 12 बजे तक घर पे नहीं पहुँचेंगे फॉर श्योर. राइट सर, परफेक्ट. ओके, सो ओके विल स्टार्ट. ग्रेट. रुको ने मैडम, पूछा जबरी तमने बધી. सो गुड मॉर्निंग वंस अगेन टू एवरीवन. नाश्ता किया? सबको नाश्ता मिला क्या? नीचे रेस्टोरेंट में उतनी गर्दी में हमको नहीं मिला. अरे नहीं, चम्मच नहीं मिला मेरे को. कंप्लेन करके आओ दिव्या को मैं. हाँ, मैं कंप्लेन करके दिया, चम्मच तक नहीं है तुम्हारे पास. मेरे को नहीं खाना खाने में निकल रहा हूँ, पार आ जाता हूँ ऐसा. वो तो मेरी बच्ची ने मेरे को खिलाया तो मेरे को खाना पड़ा. ओके, सो वी वेलकम डॉक्टर अवंती एज आवर को होस्ट फॉर द डे. सो अवंती मैम, हाउ वाज योर डे? कम हियर. अरे वो छोड़ना, स्क्रिप्टिंग कौन करता है तेरा? स्क्रिप्ट बुक में से पढ़ेगी तो कुछ क्या, कभी तक एमबी में से बुक पढ़ के नहीं किया हम लोग ने. सो हाउ वाज योर डे यस्टरडे?
इट वाज वेरी नाइस.
शी वाज वेरी हैप्पी बिकॉज कल शैनिल आया था और बच्चों की भी ना सोचो क्या मजे रहेंगे उसके. राइट, चलो विल स्टार्ट विथ आवर डे. एज वी से वी हैव अराउंड 5 to 6 lectures with our KVC and 1 workshop or neural talk.
Yeah. So good morning everybody. Let me start by saying thank you. We know being here in the conference hall early and bright Sunday after having an eventful night before and heavy breakfast in the morning requires a special kind of dedication and perhaps a very strong cup of coffee. We appreciate you all being here to keep the momentum going. Yesterday was truly remarkable. We kicked off the conference by exploring evolution of AI in the field of medicine. We saw advanced technologies in different medical fields and also good panel discussion and informative workshop. The energy in the room and the debates in the hallways made it clear that we're standing on the edge of a new frontier in the medicine. But if yesterday was about understanding the what and the whys of medical AI, today is more about topics like oncology, financial OPD, modern cardiology, and neurology. We have an incredible lineup of speakers today who will guide us through all these. Also, not to miss, at the end of the session, we're going to have a KBC quiz session. The underlying current of MEDIMEET 2026 theme is partnership. AI is an incredible, powerful tool, but it is just a tool. It lacks empathy to comfort a frightened patient, the intuition to read between the lines of a complex medical history, and a moral compass to make difficult ethical decisions. So our goal for this MEDIMEET is to figure out how best partner human compassion and clinical expertise with powerful tool like artificial intelligence. Thank you once again for your time on Sunday morning, and let's make the day 2 better than day 1. Yes, Rajesh.
Thank you. एंड अर्ली बर्ड कितने आज के? कौन सर? आपको मैं पहले काउंट कर लिया, तो उसके अलावा 4 जन कौन है? 2। आपका नाम होना चाहिए धारणा के पास। धारणा, ये जो सब लोग हाथ ऊपर कर, उनका नाम है क्या? वो पोस्ट में रेजिग्नेशन दिया हुआ है। हाँ, धारणा ना पर रेजिग्नेशन आप एम के Okay, so before we proceed, I'd like to call upon stage our President, Dr. Paresh Mehta, to please say a very beautiful good morning. Please, sir.
गुड मॉर्निंग एवरीवन। ड्रम सर्कल अच्छा रहा, आज ब्रेकफास्ट भी अच्छा रहा, तो जोर से जरा गुड मॉर्निंग। Okay, so I welcome you back again. Today is also, we are having a very good sessions of all the eminent speakers that we'll be entitled to. At the same time, after the speaker sessions and the lunch, we will be leaving for Varad Vinayak and also for Srimad Rajchandra. So too many itineraries today also, and you keep the joes that we had to yesterday the same way. Thank you once again.
Okay, I'd like to call upon Shri Secretary Dr. Meenal Panchal. आ जाइए मैम। Our organizing chairman Dr. Ashish Modi sir, please. IPP Dr. Jignesh Mehta, please. Dr. Pratik Jhariwala, our treasurer, he is not there. So but check तो वही sign करेंगे। Okay, so I just declare the early bird, फटाफट आगे आएंगे and just collect your early bird, नहीं तो मैं लेके घर पे चला जाऊँगा। Okay, तो early bird for the day is Dr. Seema Verma, Dr. Gaurav Hatangadi, Dr. Sangeeta Shoyi, Dr. Kirit Davda and Dr. ML Bhupti. Please sir, आ जाइए, come. फटाफट। अरे ये खाली शुरुआत है आज के गिफ्टिंग की, बहुत सारे गिफ्ट है आज तो। सर आज तो गोल्ड और सिल्वर दोनों होंगे ना आप?
After the first session, we'll be announcing either the gold or the silver coin, depending on the number of attendants. So I want everyone to be present. Your friends and colleagues who are still in the restaurant, you may please call them up. एक के बदले में 2 अच्छे, जो मिला बांट लेना, ठीक है? So I need everyone to be present for the bumper prizes after the first session. Thank you.
We'll have photo. अवंती आ जाओ ऊपर, please. Yeah. सर आपो છો કે લો છો? गिफ्ट आपो છો કે મને આપો છો? આ गिफ्ट મને આપી દો ને प्लीज। थैंक यू सर। नहीं मेरा है, मैं पहले आया था, मैं आके सेटअप चेक करके गया। भुप्ती सर तुमचं नाव घेतलं मी घेऊ? मी घेतो। नहीं सर आके साइन इन किया और चले गए घर पे वापस। थैंक यू सर, प्लीज। सर गिफ्ट कलेक्ट करा, नाही तर मी घेऊन जाणार। सर ऑन दॅट साईड, गो दॅट साईड सर। हां चालेल। माई वासे शे आय हॅव माय लॅपटॉप। माझा लॅपटॉप घे ना, माझा लॅपटॉप। येस सर, थँक यू सर, थँक्स अलॉट। अवंती Okay, we'd like to thank our platinum sponsor, New Wins Neuro and Multi-Speciality Hospital, our gold sponsor, Heart and Vascular Super Specialty Hospital, and Neon Laboratory Private Limited. Our chair cover sponsor, MOC, our Gala dinner co-supporter, Pulse High Tech, and our gift sponsor, Glenon Healthcare. आप लोगों ने गिफ्ट खोल के देखा घर पे किसी ने? मिला? अरे आपकी बात अलग है, आप ये वाली पार्टी में आते हो। एनीवन ओपन द गिफ्ट? नहीं? देख सर ने पहना, खड़ा सर। वेरी गुड। हाउ इज इट सर? यू ट्राइड इट? That's why I ask कि किसने ओपन करके देखा, because हमारे पास AI वाला बंदा है जो who can do this thing for you. आशीष सर, your help will require for this thing. ऐप कनेक्ट करने के लिए रिटर्न गिफ्ट तो आपने दे दिया, यूज कैसे करने का? हो जाएगा, हो जाएगा. सो विल रिमाइंड अस, अगर हम भूल जाते हैं तो डेट वी हैव टू डाउनलोड आवर ऐप. QR code, he will give the QR code. Everyone has to download app on your mobile and then will be able to use your Android watch. Great. So ready? इसका पे हुआ? He'll do that. अच्छा, उनका presentation यहीं पे लगाएंगे ना हम लोग. So कहानी की रुकावट के लिए खेद है. मेरा कुछ नहीं रहा, हो गया. हाँ. So we'll for first session we'll like to call upon Dr. Manish Jain. Sir, please. He is our first time you are a BMB committee member. So we are welcome you, sir, to the BMB committee family. So I'll request you to please introduce our first speaker, Dr. Ashay Karpe, sir.
Good morning, friends. Yeah. So for the first lecture today, on the day 2, we have the topic of medical oncology and challenges in day-to-day practice. The eminent speaker is Dr. Akshay Karpe. He is a leading medical oncologist, hematologist, and stem cell transplant physician. He is a director and founder of Sunrise Oncology Center and Sun Act Cancer Institute, and also serves as a president of the Clinical Research and Statistic Foundation. Dr. Karpe completed his MBBS from KEM, MD, the gold medalist, fellowship in clinical hematology, and DM, DNB in medical oncology, both gold medalist. Gold hi gold hai. He has been recognized with the Homi Bhabha National Institute Best Medical Student Award and the Golden AIM Award for Excellence and Leadership in Healthcare. With his vast expertise, he continues to make outstanding contribution in oncology, hematology, and stem cell transplant. Let's welcome Dr. Akshay Karpe. Welcome, sir.
Good morning, everyone. This is Sunday morning and there is so many people present. So, I'm happy to be associated with BMB for since 1998, from the student till the faculty. I think it's a very long journey, but, it is always nice to see, So I usually don't miss BMB annual meets. So just to begin with, what I'm going to tell you is not oncology, actually, to be very honest. Because, this time, actually, last time I've taken a lecture, so that time Dr. Panchal and Dr. Mehta suggested ki, tell us something about what actually is happening into a practice. What are your experiences? And so this is my disclaimer. The presentation is based on real life experiences. If you have come across this situation, emergencies, people, allegations, or you have witnessed it, it is not a coincidence, it's reality. So what, first of all, I'm trying to tell you, see, the thing is that there are various instances, now, I mean, since the morning, I'm interacting with a lot of delegates, and what we have seen, there is a paradigm shift in a private practice. It is not the same as it used to be when I used to go to my family physician, and now it's quite different. So, this is definitely new drugs, information, and guideline updates, So every now and then, we need to update ourselves. It is not that easy, Maybe one antihypertensive I was using maybe way back. Currently, any patient comes with blood pressure, diabetes, I don't give them any medicine. Despite I've done my MD medicine, I tell them, no, you have to go to the doctor because every now and then there are new things. And I'm in the field of oncology. So this is just, approvals. So you believe me, currently, if anybody comes to you and asks you what career I should follow in medicine, and it is oncology only. Why? Because, see, oncology dominates the innovation. And why? Because cancer is something which is incomplete science, I always say. We are yet to. See, cardiology, now there was a time when bypass means buy. Now it is almost, everyone does bypass, minimally invasive, within 3-4 days they are discharged. Angiography is purely on the OPD basis we can do. So you have reached a pinnacle of that treatment. But oncology, still our survival are in the 10 of 40 to 50%, if I'm taking a ballpark figure, There are certain cancer where can be 80-90%, there are certain cancers 10-20%. But still, it is an incomplete science. So it dominates innovation. So in FDA approval, I'm saying 2024 to 25, 30 to 35%. So you imagine how many medical branches are there. 35% of the new drugs have come in oncology sector itself. Well, other field like infectious disease, which is the commonest, only 10 to 15%. Neurology 10 to 12%, cardiovascular 8 to 10%, rare diseases 15 to 20% with some sort of genetic therapies. And this is the most important thing. Now I have to keep my laptop always on because what guidelines have changed, I really don't know. And this is something. Lung cancer guidelines was revised 5 times in 2022. So I might be telling a patient something, and now with the ChatGPT, patient already knows something. He will say, sir, you're following an old guideline. Please go back to the newer guideline. So lung cancer guideline was revised for 5 times in 2022. Breast cancer was 3 revisions in 2023. Well, prostate and colorectal, 2 to 3 revisions per year keep happening. So I might have read something, and the patient comes, it is already old. So what I need, I always keep my guidelines on. I tell my patients, see, there is no harm, to tell the patient. Sometimes what happens, some rare cancer comes up, I tell patient, you don't pay any consultation today, just keep the file with me, I'll study, you come back tomorrow. I'll just go through. So this is something, because why? Because rapid drug approvals, the drugs which I even can't pronounce, sometimes to prescribe the drug, I open my Google and see what is actual spelling of this drug. The breakthroughs of the biomarkers and the resistance mechanism, dynamic treatment, global trials, and in contrast, so field like cardiology, endocrinology typically update guidelines in every 2 to 3 years. Oncology guidelines are updated every 3 to 4 months. So that is something which keeps on a toe. So almost I've stopped practicing pediatric oncology. So I've now pediatric oncologists are with me. So I don't practice because we need to remain updated because this is an era which is medical legal thing is one thing, but you should be updated before you do. Now, this is something, increased health cost. So we say the laughter is the best medicine. So your medical insurance only covers laughter, which says is the best medicine. So doctor tells a joke. So this is not what I'm saying. So if you typically, if the patient gets admitted in a corporate hospital, bill is high, the blame is on a doctor. कि ये doctor ने मुझे वहाँ पे admit किया और इतना bill आया. So I will give a simple example. I was there in a corporate hospital, I was treating aplastic anemia. The drug costs are whooping. The patient ultimately succumbed. Bill was 8 lakhs. So he went to the HR, whatever, the accounts department. They said कि bill कम करके दो. तो उन्होंने बोला कि डॉक्टर जितना डिस्काउंट देंगे उतना ही हम भी डिस्काउंट देंगे उतने % में. So then he came to me, my cabin, sir, I want a discount. So मैंने बोला कि have you gone through the bill first? तो उसने बोला नहीं. So मैंने just go through the bill, entire bill. 8 lakhs is your final bill, just go through the bill. Then he found my charges was out of that was only 5,000 rupees because of the single visit. So I think out of 8 lakh, what is the 5,000? So then he said, yes, sir. So I go back the administration, tell them, Dr. Ashe is giving 100% discount. They said, in proportion discount. So I'm giving 100% discount. So now you give it 100%. So what I mean to say is that increased healthcare costs is not doctors are responsible for it. Just always saying, now the small nursing home and the things, they're dying actually, There's you don't get staff. People want it to go. So people want less charges, but a 5-star, ambience. So this is something which is not there. And the next thing is that the amount of money spent should be directly proportional to the outcome, And oncology, we have newer drugs, like many of you know, now always we have to remember the example of celebrities. So Sanjay Dutt, he had stage 4 cancer, immunotherapy, a drug called pembrolizumab, that used to cost 5 lakh rupees per dose, and you have to take 2 years every 3 weekly. So imagine it is 2 CR. So yesterday only I went because its patent expired. Now it is just 4 lakh rupees a year. So it changes so much. So that is where I come, prescription. This one is a miracle drug because if you can afford it, it's a miracle. So that's the main thing which is happening in oncology. But yes, so all these things, they keep happening. So now what happens, as I have done my training in the government institute. Most of the times we take our decisions for the patient on our own. This patient cannot afford this or this, and we wanted to save because what happens, especially in oncology, where outcomes are never guaranteed, patient might sell their land, might sell their assets, get their banks. I always ask my patient, how you are going to pay for this? That you first tell me, then. But then I realized this approach may not be right because many of the times what happens, I have told something, patient was actually not affording, But some relatives pops up. Immunotherapy was the ये अच्छा आया है आपने कभी ऑफर ही नहीं किया. I said they can't afford the basic drug. Can they afford immunotherapy? नहीं आपने देना चाहिए था. आपको किसने बोला है ये? So now that's the reason why I say this is called as a cafeteria approach. Cafeteria approach मतलब क्या? If I have 100 rupees in my pocket, I go to the restaurant, I will check the menu card. The dish which is less than 100 or 100, I will be ordering. If anything is 500, I will not be ordering it. So give your patient something called as a cafeteria approach. Why? Because, now they wanted to say, now there's a COPRA, basically becomes under Consumer Protection Act, so many things. So I feel, now I write all the possible options which are there ensured in the guidelines. And I tell them, this is something there. And the thing is that never do the financial counseling yourself. Because it becomes like, sabzi wala. Ye 10 ka 5 mein de do types. So keep a financial counselor. So I have kept a financial counselor. They speak with the patients. Why? Because see, as a doctor, we always have, people expect noble profession, they shouldn't charge anything. No. So I think we have to ensure this, that we should give a cafeteria approach to our patients. These are all options. These are what is the outcome, what you want to do. This is something very important, and I think now as a doctor, which we used to take a decision, maybe, my family physician used to take a decision for us, you go there, here, now it doesn't matter at all. Now everything boils down to you if you have taken a decision. So give your patient a cafeteria approach, because there's a patient education, understanding, there are a lot of provider burden, decision complexity, coordination challenges which are there, so don't take onus on yourself. Yesterday you had an excellent session on AI, so I don't think I will require much of the AI, but this is what is something which is happening, chat GPT, and I will give an example, So I was giving one patient immunotherapy, and so immunotherapy side effects is usually autoimmunity, but usually it happens after 6 to 7 doses. So he had just taken 1 dose, and he was just, his father was just coughing. So he came to me and said, I have just asked in chat GPT, and he said, the drug pembrolizumab causes pneumonitis. So does my father has? I didn't say anything. I write on the paper HRCT thorax. So he said, sir, why you have written for simple cough HRCT thorax? No, just now you said that your chat GPT has diagnosed this as a pneumonia. And this is drug-induced pneumonia. So better get a HRCT thorax done. No, your clinical judgment. Like sometime back it was your judgment. And now if I give, and actually it happens, then onus is going to be on me. I'm not going to treat you further unless you have got your HRCT thorax done. Because you have said, this is a pneumonia. I've documented on the paper. The patient has suspicion of pneumonia, cough. You do HRCT thorax and come back. But why I'm saying so? This is not what I'm saying. See, the thing is that this might be a simple thing to appear, and sometimes, and this has happened again in the similar thing. Normally, if we see all cancer patients, even if they have completed cure, they will keep asking me, can I get my PET scan for follow-up? And I always say no PET scan. Why? Because PET scan is essentially to detect stage 4 disease. Before I plan a surgery, before I plan a radiation. So stage 4 disease I'm not interested in. Why? Because I cannot cure it. So if the patient is asymptomatic, PET scans are not supposed to be done. Why? Because you will give patient a different mentality, because sometimes PET scan pick up something nonsense. It can be infection or something, but patient will become restless. Now I have something. So never over-investigate, but because of the chat GPT. So, many of the times you will see this, the extra charges for arguing with me from what you have read on the net. So, we laughed about this joke, but I think now the era has come, you have to go for option 2, where you have to incorporate AI. And how did I this so? So I have got a paid version of now ChatGPT. Because you have unpaid, it is just going to be very conservative, but you take a paid version. So I use actually Microsoft Copilot. I don't use ChatGPT. So patient came with me. These are the 3 regimens which my mother should be using for her blood cancer. Which one you think is a better one? So I said, see, the thing is that in the ChatGPT, what have you put? So he said, my mother has a blood cancer, and this is what I put, and these 3 regimens have popped up. I said, okay, now I will give you comparison of these 3 regimens. So I put in my ChatGPT, and I give with all the studies, and now you can go through the records. His ChatGPT printout was 1 page, mine was 5 pages. I said, just go through it and come back. Then again he come back. I said, still, this is not applicable for your mother. Why? Because you have not told ChatGPT that your mother had a breast cancer, and she has received this one drug. This drug has a lifetime, upper limit of dose. So there is a drug called anthracycline. They have lifetime upper dose. You cannot cross that dose. So she has already received that, so you cannot. So now you tell the ChatGPT that my mother had a breast cancer, she has received anthracycline, now what should be done? So what I mean is that I cannot keep arguing with this. So rather than this, nowadays somebody comes with why this is done, my guidelines are always on. I take a printout of the guideline and I highlight what I have done as per the guidelines. So we have to use this. We cannot say this, go out, or we cannot put it on our walls ki if it is a AI-based diagnosis. No, we have to adapt to it. And this is something what we say, ki what will be the impact of ChatGPT on the business? No, only that we want to adapt it everywhere as fast as we can. There is no exception to the rule. And see, the thing is that this is always technology. Maybe, there was a point of time, people now used to say the clinical examination is a dying art and other things. No, it's not a dying art. I don't want to die. Because my patient will say, you have not done this investigation and somebody has done this investigation, this was found. So we want it to be safe. So that is something which is changing in the practice. So what is AI? Enhanced diagnosis. So now all radiologists, a simple lung nodule is there, it will tell whether it is a cancer or not. So there are algorithms which are there. Personalized treatment. So now cancers, they don't require same treatment. Each cancer is genetically modified and then we find out. Clinical decision support, as I said, now something new comes up, I put it on the ChatGPT or my co-pilot and I found out what exactly new thing is happening. Biomarker discovery. Now I have attended AI. AI can design drugs now. So you don't require scientists also now. So you tell this cancer has this modality and this is something which is a Parker pathway, which drugs can be. It can create some molecular structure. Almost it can create within one day 200 odd drugs. It can create, AI can. So this is something which is more important. Now this is something, second opinion and medical jousting. This is something what I just wanted to. So, I have already diagnosed myself on the web, but I have come for the second opinion. So this is something which you will commonly see. And I will tell you, one patient has come to me and, she asked me, so I just put my opinion. Then she said, yes, I'm going to take treatment with you. What happened? She pulled out 10 different doctors' papers. And she put it on my table, said, all these are opinions. Yours is the only opinion which is matching with the Tata hospital. Yes, it will match because I'm trained there only. So... So the thing is that I'm going to take treatment with you. Why? Because your opinion is matching with the Tata. So many times I tell you, patient ask me कि doctor आपने ऐसे लिखा और उन्होंने ऐसे कैसे लिखा? तो मैंने बोला कि what are you? तो he said कि I'm Maharashtrian. And what is your neighbor? बोला कि वो पंजाबी है. बोला तुम्हारे घर में दाल बनती है, बाजू वाले के भी घर में दाल बनती है. तो कभी बाजू वाली से पूछा कि मेरी वाइफ ऐसे क्यों बनाती है करके? So what I'm trying to tell you कि you can take 10 number of opinion. ये दाल किसने बनाई? But you have to choose one. महाराष्ट्रियन खाना है अपने घर पे आ, साउथ इंडियन खाना है बाजू वाले के घर पे जा, बट यू हैव टू चूज, अदरवाइज तुम हंगरी भूखे मर जाओगे. सो दैट इज समथिंग विच इज इंपॉर्टेंट. सो वी डोंट से दिस इज समथिंग विच वी शुड बी अवॉइडिंग. मेडिकल जॉस्टिंग इज द आर्ट ऑफ it's uncourtly clinical criticism, a noble name for an incognizable activity. So we shouldn't be doing that. And that is something which is, I always tell people, see, we are not competitors with each other. We have to understand we are as a community. There has to be coordination, So still sometimes somebody asks me, this doctor has written this, why you have written this? See, that's a clinical situation at one particular point of time. You were there, what scenes were there? I cannot, again, simulate all these situations. So this can be very, direct verbal. This has happened to me in the, you should take the legal action against this doctor. This is a direct way of medical jousting. Indirect, oh, this shouldn't have been done. Your one sentence, they pick up that one sentence. Or body language, you just show your face. So body language, written in the patient, the previous doctor has done this. Or the written in the patient's record. So see, the thing is that the patient belongs to nobody, by doing this. And I will tell you, this is again an example. I will not name the people because, that creates a problem. So the thing is that somebody has written a chemotherapy, they have not taken, they have come to me, so I have given. And I told the patient, see, your disease is very bad. Somebody might have promised you that they are going to do surgery after this chemo, but yours is already disease stage 4, which scans which I have reviewed. So apparently, he had a response, but was never operable again. Then surgeon commented, you have been given a pediatric dosage, that's the reason why you have not responded. Now patient came fuming back to me that I have been given wrong dosages. So now there is no option. So I told him, you have my papers, you have everything, go to the Tata hospital and verify it. So he went to the Tata, they said, no, all dosages, everything is right. And they reviewed the scans, they said, you were stage 4 from beginning. How somebody is going to operate you? But what I'm trying to tell you, see, it's very easy to say here, but that one incidence actually takes whole of your days, weeks. You are already stressed out. You cannot just take these things out. And this is something which just keeps constantly happening. Now you have so many gadgets. We are so happy, the camera is in the pen and this. So now people record everything. So you have to. So there was one instance, like somebody came to me and, so this phone was on and, it was quite visible that I was moving, even the camera was moving. So I just asked him, you are a very nice gentleman. if you invite me at your home for a dinner and I start, recording your wife and your daughter, what you will do? So he was like, Agas, he realized, no, I will shout at you. No, you will hand over me to the police because that is my private property. You should have taken the permission. Then immediately, no, I will delete it. See, but this instance, see, I could, but now there are so many gadgets. It can be in the button, it can be, so many other times, even second incidents happen, The patient came to me for second opinion. I was just going through it, and he was asking only one thing. Do you think this doctor has done anything wrong? Do you think that, what are you asking me? Well, have you come for a second opinion, or what do you have come for? And then I realized their camera and mic was on. So I didn't say anything. It was about very senior most onco-hematologists in our field. I said, see, first of all, you can switch off your camera, switch on your camera, whatever you want to do. The treatment is right. And the thing is, that person for whom you are asking about, even when I was not born, he was practicing this. So something, you remember, you can be on a camera and everything, and you cannot stop it. This is everyone would have heard, the daughter from California syndrome. So it's an irresponsible person complains about. So this has happened again in my clinical practice. A very elderly couple came in stage 4 lung cancer, and so I saw, many times they don't have anybody. So I used to tell my mama, mausi, or sisters, please go to the pharmacy, collect their medicines, bring them. And for last 3-4 months, I've stopped the treatment because I told them, no, there is no point, because, And one day, she had a MI during OPD visit, so I admitted her. And suddenly, 2 children came out, And then I asked you said you are orphan, and now suddenly you have 1 son and 1 daughter. And they were fighting with me that our mother treatment was over and she was very well. Who told you? My father. Luckily, we follow electronic medical records, so all my notes, even with the patient, get scanned and they remain with me. I took the printout of all their last 7 visits. Everywhere I've written, this patient is terminally ill, no treatment to be given, best supportive care. Now they're starting in front of me that she had a heart attack, you should have done the angioplasty. Who on the earth stage 4 lung cancer going to die in next 4 to 6 weeks will do angioplasty? No, we have taken an opinion, you should have done angioplasty. But what I mean is that this is something, what is daughter from California, they are never there throughout their treatment. Now they wanted to suddenly show care, concern, everything, And the easiest punch too is a doctor, the softest target. So I always say, documentation, because everything was documented. I just showed them the paper and then they went away. So I always believe, somebody comes, gets cured and, try to touch feet, say, I'm not a god. Absolutely, I'm not a god. And the same doctor becomes devil, the moment, the bill has to be paid. So this is something, he was different from the other doctors. For one thing, he refused to play God. And I do that. I refuse to play God. Because, God, जब तक अच्छा चल रहा है चढ़ावा आएगा, जिस दिन होगा यार तू पत्थर का भगवान तुझे क्या समझता है, So I don't want to play God. I am a human being and come to me like a human being. This is something which is more important. And see, in my field, because I will tell you, in Tata Hospital, almost there is a 50% attrition rate if somebody comes directly from MD medicine. And why so? Because oncology, many of the things are palliative. When Tata has a huge load. I used to say, I used to see in lung cancer OPD, 100 and 120 patients, only 10 curable, 110 not curable. So as a MD medicine, I'm not used to these things. So they get so much depressed. So it is, we have to understand that I am not a god. I cannot cure everybody. I have to be in limits. What happens? Because this take a toll on you. And see, we are not, it's a Gautam Buddha, whatever is happening around, I am not touched by it. No, we are a human being. And that is what something we need to look for. So compliance to trollop, you might be writing drugs on the paper, but patient is actually not taking it. And every time you are wondering what actually is happening. So this is, do you solemnly swear to listen to my advice? So this is a time has come, actually you are following. Because many times I have said, the patient was following with me. I have writing a drug. He was taking some alternative therapy, but getting a PET scans done, and he used to come to me. What should I have done? I said, you are not taking a therapy. What is the point of getting? No, I am doing alternative therapy. You just monitor. So just ensure before anywhere you change anything, whether your patient is compliant. I think and sometimes we follow celebrities. Somehow, we have this, So even I'll say, mankind wants to have, because brand ambassador this, So basically, when they are promoting, it's ethics. They say a doctor cannot do because money is involved. So they are doing it free of cost. So definitely. So they are the brand ambassador there. But the thing is that they are going to sell these things. And this is what I'm going to see. This is called as the Angelina Jolie effect. So Angelina Jolie effect, what was? So there was a time when I used to counsel my patient about the genetic cancer. They used to run away. Don't label my family as a genetic cancer. Nobody will marry our daughters, nobody will marry our sons, everything. But when Angelina Jolie, Angelina Jolie, she is a genetic cancer carrier, a BRCA gene. So in that, breast cancer and ovarian cancer is common. So what she did, she had done bilateral mastectomy. So breast tissue has been removed, put implant, and uterus, bilateral salpingo-oophorectomy has been done. So ovaries have been removed. So the part where a tablet insert can be developed, it is called as a prophylactic surgery. But the moment she did, you read this, 64% BRCA testing increase in just 15 days in US, 37% higher all year. Mastectomy rates almost declined. In Korea, almost 5.8% preventive mastectomy, I am saying. The females went for the surgery. 3 to 6% ovary removal. Here you have menorrhagia, you need to convince the patient, ki, "Arey Baba, get it done, otherwise you will die." 8 times surgeries in the unaffected BRCA carriers. Again, in China, also 1.9 higher BRCA testing willingness, strongest counseling. So what I mean is that use these opportunities. Because we really can't do anything about it. So anything have to sell has to be a celebrity. Now this is something which is there. Okay, doctor has to be available 24/7. So one of my patient came to my OPD and started arguing me. Like, what happened? You are not there on Saturdays, Sundays. You don't sit late in the evening. I have to, take a leave from my office. So you have to, because you have to come only for one day, but I will have to follow this protocol all 52 weeks. So he said, no, you have taken oath. I said, I will send you a copy of oath. There is no mention of Saturday and Sundays. So you can just go through it. There is nothing has been written of Saturdays, Sundays, nothing. I will send you the forward. But what I'm trying to tell you, this is something which is a mentality. And I think, one day I was passing by, IC colony, like those who stay. There is a nighttime clinic, Bombay night clinic, which runs between 10 to 7. Yeah. So what I mean is that, see, when I used to do morning OPD, people used to tell me, keep it in the afternoon, traffic is less, we finish. When I kept in the afternoon, they said, no, evening my son comes late, you keep it in the evening. Then come night, then come Saturday, then come Sunday. So one patient was hell-bent that, you should keep OPD on Saturdays or Sundays. Why? Because my son has a holidays on those days. I said, my mother's son also has a holidays on those days. So the thing is that you really can't argue. So I tell I'm oncologist, and when I'm at home, I'm ophthalmologist. So I'm absolutely off the work. So you also need to take. See, we cannot be. So now also what I've done, I've taken one mobile, because now the thing is that it's imperative. WhatsApp you get lots of. So there is one WhatsApp. Patient is supposed to message all reports, everything on that number only. You cannot reply on any other number. So, people can ask anything. Last and the most important is social media and medical profession, So see, social media usage in healthcare marketing, this is the data, and you can see Facebook up to this. But the problem is, this is a public domain. So key challenges, your online bullying, Now, the moment they get a bad service, immediately you avoid. This is just 2 months back. Somebody was there, he was trying to tell me AI. I said, well, don't tell AI. I'm like, I will have to scrap my degree now, end of it. Let me do my examination. He was helping, no, you just see the reports and you give opinion. I said, I wanted to take history. I wanted to examine the patient, and then only I will give my opinion. He was like that. Within an hour, he put this is the rude doctor, you shouldn't go there and everything. So I said, okay. So, and whatever you update on Facebook. So, the doctor is on the travel pics. All his vacations are sponsored by pharma. So this is something where, the thing is that mentally, I will give a simple example. In the back then the COVID, so I treat very few patients totally free of cost. So there was one daily wage worker was there, and I was treating him totally free of cost. I told him, your compliance is my fee, because I know you are a curable cancer. And unfortunately, I had a very bad reaction to COVID vaccination, and I was admitted in ICU for 7-10 days. And then I came back. So, it took almost 1 month to come back of that episode. And very next day, his appointment was there, and his wife's first statement was, "हमारे patient का treatment चल रहा है और आप तो गायब हो गए." So now it's suddenly, and that remembered me. The very first incidents when I was a medical student, I joined as a MD medicine in government college at Aurangabad, and what happened. I was very good at counterfeiting signs. So many people used to come to me for their certificates and everything. So in government, there's a below poverty, you have a lot of patients are there. But actually, you believe me, I've worked in government. Those who are really poor don't have documents. And those which have every document. So, there was these Banjara people or, so what I used to do. So if those patients don't have documents, my HOD sign would be required. So my HOD was hellbent. Without document, I will not sign. So all these papers used to come, all the residents used to bring, and I used to sign. So I have signed my HOD's almost 10-15 papers. And then, so HOD has reviewed definitely sometime. And then he called me to his clinic one day. He, Dr. Ashay, please come to my cabin. So then I asked him, sir, what that you have signed in my name? So I said, yes, sir. So he said, see, I know that yours is a noble cause. I know that there is no money involved, and you have done with total humanity. But believe me, I was like you only. I have done this. That's the reason I called you. But now I'm a boss. If some audit comes in, there are no documents, I will be behind the bars. Because you have signed, and I will say that you have signed this. But just assess, is that person really worth to take your help? Because you might help them, and they will backfire, it will backfire, and then you will be repenting. So this is something which is, that is something which is there. So social media, you can have online bullying, and many times your patient sends you a friend request. Now what to do? So there's so many things are there. So I always say, see, but people say, why I shouldn't have a normal person's life? But this is something which is there. So documentation is each and important. Well-maintained medical record is a key. So it is like, where would be without the right documentation, you will be unemployed. So this is something which is there. And this is, as a patient, I'm glad because the doctor cured me, but as a lawyer, I'm sad because there is no reason to sue him. Okay, so your documentation, I will tell you, this is this is my last slide. So this is, which is happened in the COVID times. One patient came to me, it was just initial days of COVID. A patient came to me, means patient was not there, only relatives came with the file. So they came with the file, they sat on, and then I have my routine habit, patient did not come. So first, whatever is happening, I just write it, patient did not come. Where is the patient? Patient is at home. Who is given the history? Then I've written, the reports are done in the month of February, but people came to seek opinion in the month of April without any treatment. Then next. And then I told that, admit the patient. He said, patient is in respiratory distress, admit the patient. It was a CA gallbladder with lung metastasis. So I written on the paper, admit the patient, and the patient just went away. And after 3 days, and that time it was a protocol, from the hospital that PCR has to be done before admission. So they were searching, and PCR was not easily available by then. So nothing happened. Patient died within 4 days at home, and I got a call from the health ministry that because of you, one patient has died. I said, okay, what? Then they said, Chief Minister office has taken the cognizance of this case, and you have to come to the health secretary's office. What happened? There is a patient who has complained that you told them they need to get a EA, and because of this, their mother died without a EA. So I went to the health secretary's office. Now, it's a whole lot of tension that you just go for these inquiries and other things. So he said, see, I've read your paper. Your paper is clean. It is just to show, because this patient party, we have to show that we have done a formal inquiry. So that's the reason I called you. You have written clear cut that patient never came to you. You have written that they have done the test in February, came in April. You have written they have not taken any treatment. You have written respiratory distress. You have written paper, admit the patient in the ward. There is no record that they have gone to the casualty and they were refused admission. So the case is clean. So I am going to give a clean chit to you. So there is nothing to do anything. But believe this, if I have not written these things on the paper, what would I have gone? So today I was telling you, even if the patient comes 3 days late, I write it on the paper. Patient defaulted for 3 days. Because there is another incident. There was one lady whose breast therapy, chemotherapy was to be done. And, she didn't start the treatment. So I said, why you're not starting? No, my hair, I will lose my hair. My daughter's wedding is there. I'm going to start therapy after my daughter's wedding. So this was in the month of August. So I told her, see, rule of chemotherapy after surgery, within 12 weeks you have not done it, it is useless thing. So they came in the month of November. Now I've written on the paper. Now the role is doubtful. She's already stage 3. So that is the reason why there is a high chance of recurrence. And that actually happened in the January. Despite of the chemotherapy, the disease came back. Relatives started creating ruckus in the hospital. What is this nonsense, doctor? We have given such a heavy dose treatment and other things. And they started creating ruckus. So hospital admission called me, what is happening? She's on so many expensive medicine. Just get my papers. So all papers are now EMR. So I took out the printout. I showed them. I have written the treatment in August. It was started way back in November. And I've written, now there is no benefit of therapy, but as it's a high-risk disease, we are offering this therapy. Then they suddenly, her daughter ka shaadi tha na sir, kaise hoga? Now the tone suddenly changed. So now the owner. So what I mean is that, see, you can be anything, but only thing is going to save me. And again, this was the same teacher, HOD is training to me. He told me, see, first of all, assess the person is worth for your help or not. And second thing, even if you want to give a poison, tell the sister to chart mark as a, Amrut. Because in the court, that paper is going to come. that simulation, that scene is never going to come. So remember, your papers has to be done. So just take home message. See, medical field is vast. Regularly update yourself. Communicate with your colleagues. See, we are not competitors. We have to understand one thing. I'm not a competitor with anybody. I still talk with my colleagues. Yesterday night only we have a Tata alumni meet, and we talk to each other, and then we realize everyone is going through the same phase. While counseling, patient give clear idea about treatment cost. I document everything and use cafeteria approach. Do not take decision. When the time has gone when we are used to take a decision for our patients. And your technology are there to say, rather than criticizing, avoiding, try to adopt them for the better practice. Say no to medical jousting. Use your words wisely. Whatever your one word can create anything trouble. While counseling and patient care, you're always found out who are the decision makers, because they are the most important notorious thing. Document their name. So whenever I write who was there. So patient was accompanied by son, date, time. You write everything. So they are more important. Doctor is not God, not devil, not celebrity. He is a mortal human being, and that's a fact. Oath has not included 24/7 duty. So take care of your health and family. Pursue hobbies. Make good friends. Enjoy life. I think Dr. Ashish Modi can take that lecture. Avoid burnout. That's the most important thing. Judicious use of social media. So if you are using social media for your promotion, be ready that there are going to be, because many of the times it happen, even your competitors also can put some, corporates also can put some on your page. So you have to be ready. Because you cannot remain silent. Proper documentation is the key. Any issues which happen, I think BMB is a lot of supportive. I've seen this, any problem happen, Pratik was there, Dr. Ashish was there, everyone, Dr. Ashish, everyone has come through. So I don't think so. So be in a touch, any issue happens, discuss with your colleagues, discuss with the office bearers, organization, BMB, IMA, share your worries. So what you are happening, you are having any problem, and attend BMB meets regularly, probably, because this is a time I think you should get. See, the thing is that I think I was just discussing with everybody, it's just 3 days time, right? It's a Friday, Saturday, Sunday, even I wanted to join, but unfortunately my father-in-law had MI, so, he's bypass, and that's the reason I was saying the third speaker is going to operate my father-in-law. So better be on a time. So the thing is that all these are meetings, these are the, this is nothing to exhibit or something. This is something, you come across. Speak with your colleagues. You will understand. Probably your problems are not the only one. Other people might have the same problem. What can be the solutions, And this kind of the groups, I think, BMB is taking a good initiative, but I think there should be one cell, where all these grievances we can tackle, because loneliness is one of the worst illness, I will say. In the current era, we have a single kids now, almost everyone is facing. So loneliness is something where, you don't know how to, you see there are a lot of, and that's the reason why I said, just 1 month back, I went to one Karnataka, association was there for a lecture, and, unfortunately, means there was a very senior family is there, who is a third generation doctor he was. And on the day when I went, so that family always welcomes me when I go, and they didn't come. They just sent a message, we can't come. And the reason was worrisome. Their son was just joined a medical practice, and one of the patient has put on the Facebook and other things, and he committed suicide. So this final rites were there on that day. So, but it was so much shocking. It's a third generation doctor. I'm not saying it's a first generation doctor. I'm saying, but then see the impact is so much. That day I delivered a lecture, but that whole day I was so restless. Because this family was always, this was the third time I went there. But these all things are going to be there. So don't do. I think there's a lot of senior practitioners are there. They can always provide, but there has to be crosstalk between the various communities. There has to be crosstalk between the various branches among your colleagues, and I think probably that is the way forward. And I think that is hope. So that's saying, see, all these negative things I am telling never deter me from going back to my work. I always enjoy what I do. I'm still enjoying, but I have to change my rules of the game. That's the most important thing. I am playing the same game again, but now I will change the rules as per my safety, and that is something which is important. Thank you very much.
Thank you, sir. I request Dr. Manish Jain to felicitate Dr. Ashay Karpe.
Okay, houseful. So we'll have a bumper draw for the gold coin. कल का पेंडिंग आज फिनिश करेंगे कि लास्ट में देंगे? लास्ट में नहीं यार, इतना हाउसफुल है अभी, बाद आके लो आधे नहीं. लकी ड्रॉ, ओके, विल हैव अ लकी ड्रॉ फर्स्ट. हाँ, ओके, आशीष सर. सर हाँ चलेगा ना, आधा नहीं. दिस इज फॉर लकी ड्रॉ एज ऑफ नाउ, नॉट अ बम्पर प्राइज. डॉक्टर फोरम मेहता फॉर अर्ली बर्ड. गोल्ड कॉइन नहीं है, पहले बता रहा हूँ, गोल्ड कॉइन उसके बाद आएगा. ओके मैम, ओके, यू आर गेटिंग फोट्रॉनिक रिचार्जेबल बैटरीज. आलो भाई, ये आपका नाम ना बताना. ओके, आई रिक्वेस्ट परेश सर टू कम फॉरवर्ड. सोना है तो सोना नहीं है, ऐसा है, प्लीज आइए ऊपर ऊपर बढ़ती जाए. अच्छा क्या दे रहे जा जी सर, आप भी जाओ. मीना मैम आप भी जाओ. बीएमबी में गोल्ड बढ़ता है, सबको जाके बोलने का. ओके, एवरीवन टू से दैट बीएमबी गिव्स यू गोल्ड, तो देयर आर चांसेस यू विल गेट गोल्ड फ्रॉम देयर एज वेल, राइट? गोल्ड 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 है, और लकी ड्रॉ में गोल्ड निकलेगा अभी. ए भाई सर, हाउ व्हाट आर द थिंग. ए रुको रुको, पहले चेक करने दो कि पक्का गोल्ड हो कि फॉइल लगा के दे रहे हो. सब पक्का ही रहता. ओके, 999.5 ग्राम ऑफ गोल्ड बाय बॉडी मेडिकल ब्रदरहुड. सो देखो कर, एक मिनट समझो, जिसमें से नाम निकला और वो यहाँ पे नहीं रहेगा तो उसके रुकना भाई, मैं मेरा सेटिंग कर रहा, तो बीच में किधर कूद रहे हो. हाँ वो तो समझते नहीं है. ओके, तो उसके बाद आप और कितना निकालोगे? उसके बाद और एक कूपन निकालोगे. ओके राइट. सो एक काम करो, आस्क योर पार्टनर टू प्लीज जाओ वॉशरूम जाके आना. ट्राई फॉर दैट. आस्क योर पार्टनर टू गो एंड गो वॉशरूम एंड कहते जाके आ जाओ. दैट प्रोबेबिलिटी इंक्रीज. हाँ. ओके, सो विल हैव फर्स्ट कूपन फॉर अ गोल्ड कॉइन बाय मेडिकल ब्रदरहुड. हाय हाय हाय, जोर से थोड़ा. कल ड्रमिंग सेशन किया है ना, तो करो अच्छे से. हाँ, एंड द प्राइज गोज टू डॉक्टर परेश मेहता. आपका ही नाम है.
The lucky one is Dr. Jasmine Patel.
Congratulations मैम, फॉर द फर्स्ट टाइम इन बीएमबी. या देखो, मैंने बोला ना.
We take a commitment that you'll be attending the MEDIMEET again and again.
या प्लीज मैम. थैंक यू मैम, थैंक यू. इसके बाद कितना और देगा सर? और 4 रहेगा ना इसके बाद? और 2 है. 2 more to go. So I request Dr. Paresh Mehta to please introduce our next speaker.
Manish Bhai is doing the honors. Gold coins,
नहीं उधर तो नहीं है. हाँ अभी हुआ, अभी होएगा. हाँ करूँ, प्ले करूँ. पेन ड्राइव चलो ठीक है. ये लो, सॉरी. लगाओ. कौन सा है इसमें?
BMB का भी वीडियो ना, BMB 26 2026 इवेंट.
ये वाला. ये नहीं है, स्पेस नहीं है, इनका ख़त्म हो गया स्पेस. डायरेक्ट लैपटॉप इधर से किया.
नहीं आ रहा है, स्पीक आवाज़ नहीं आ रहा है.
Friends, as a doctor, we are used to health OPD. Today, we are going to attend a different OPD, a financial OPD. I call upon the stage the Managing Director of F2 Funds Private Limited, Mr. Nehal Parekh. He is managing assets worth 700 crores and most of them are retail clients. Let's welcome him.
गुड मॉर्निंग. यस, कितने पेशेंट है ओपीडी में आप लोग के आज? आप लोग के तो नहीं है, बट मैं बहुत खुश हूँ, मेरे पास बहुत सारे पेशेंट हैं. राइट, ओके, तो थैंक यू वेरी मच BMB फॉर गिविंग दिस अपॉर्चुनिटी. आई थिंक मेरा प्रेजेंटेशन में शुरू करने से पहले डॉक्टर आशीष जी को थैंक यू बोलना चाहूँगा, बिकॉज आपका जो टॉपिक था इट इज़ रिलेटेड विद द फिनेंस. एक्चुअली आज जो डॉक्टर्स आज आप जो महसूस कर रहे हो वो पिछले 20 साल से हम उसको फेस कर गए हैं. राइट, बिकॉज एवरीबडी नोज कि भाई मैं भी फिनेंस कर सकता हूं, बिकॉज फिनेंस इज अ इजी सब्जेक्ट, मैं खुद मैनेज करता हूं। राइट, आज डॉक्टर हैज टू प्रूव कि भाई तुमको एडवाइजर की, डॉक्टर्स की जरूरत है, वैसे हमको भी लोगों को प्रूव करना पड़ता है भाई तुमको भी फाइनेंशियल डॉक्टर लाइफ में चाहिए। राइट, और सबके पास एक फैमिली डॉक्टर होता है, बट बहुत कम जन के पास फैमिली फाइनेंशियल डॉक्टर होता है। उसका मतलब ये है कि वो डॉक्टर को आपके लाइफ की सभी चीज़ पता होनी चाहिए रिगार्डिंग टू फिनेंस। राइट, तो ये टॉपिक मेरे दिल के पास था, इसीलिए मैंने थैंक यू कहा। थैंक यू वेरी मच। एंड आई एम स्टार्टिंग विद दिस प्रेजेंटेशन, वाई फाइनेंशियल ओपीडी। देखो, फाइनेंशियल ओपीडी जब भी मैंने ये प्रेजेंटेशन बनाना शुरू किया ना, तो मैं सोच रहा था क्या बताऊँ, कोई प्रेजेंटेशन ऐसा बनाऊँ जो प्रोडक्ट के बारे में बात करे, कोई प्रेजेंटेशन ऐसा बनाऊँ कि जो फीचर्स के बारे में बात करे, बट ये सब इंफॉर्मेशन आपको गूगल पे अवेलेबल है। वाई आई शुड गिव दिस इंफॉर्मेशन? क्या एज अ डॉक्टर कभी आप पेशेंट को दवाई की डिटेल समझाते हो क्या? यस और नो? नेवर। आप खाली उसका इलाज करते हो। वैसे ही फाइनेंशियल में देखो, सबसे बड़ी तकलीफ क्या है पता है हमको? जब भी मैं दवाई लेता हूं, मुझे सिम्टम्स तुरंत पता चल जाता है। यानी आज मैं बीमार हूं, मैं डॉक्टर के पास गया, डॉक्टर से शायद कोई डोज गलत ले लिया या डॉक्टर ने शायद गलत डोज दे दिया, तो मुझे तुरंत रिएक्शन आता है और मुझे तुरंत पता चलता है कि ये दवाई गलत है। फिनेंस में जो सबसे बड़ी चैलेंज है, आपको गलत दवाई ले रहे हो या गलत प्रोडक्ट पे काम कर रहे हो, ये कभी पता चलेगा 15 साल 20 साल के बाद। और रिमाइंड मी, मैं आपको बता देता हूँ, आपके पास जो बीत गया हुआ समय है वो कभी वापस नहीं आएगा। राइट, इसलिए ये चीज़ इंपॉर्टेंट था और इसीलिए मैंने ये टॉपिक रखा, फाइनेंशियल ओपीडी। अभी फाइनेंशियल ओपीडी में मैं बीमारी तो पता ही नहीं होती है लोगों को कि मैं बीमार हूँ। फिनेंस में लोगों को पता ही नहीं होता है मैं बीमार हूँ। हमको यानी कैसा होता है, वी हैव टू बिहेव लाइक मदर। जो छोटा बच्चा रहता है ना, उसको नहीं पता है, वो खाली होता है। यहाँ पे इन्वेस्टर खाली बात करता है, मुझे रिटर्न चाहिए, मुझे रिटर्न चाहिए। राइट, तो क्या होता है कि भाई मुझे रिटर्न चाहिए, बाकी कुछ नहीं बात करो। कितना रिटर्न दोगे? वो मारुति की एड सबको पता है, कितना देगी तू बता खाली। आप समझे? बट हमारा काम एज अ मदर, भाई तेरे को रिटर्न क्यों चाहिए ये आइडेंटिफाई करना होता है। व्हाट इज योर लाइफ गोल? क्यों चाहिए? बिकॉज एवरी ह्यूमन बीइंग आर अ डिफरेंट, एवरी ह्यूमन बीइंग आर थिंकिंग जैसे उनका ब्रॉटअप हुआ है। उनके माँ बाप ने जैसे पैसे को मैनेज किया था, वैसे उनकी पैटर्न बन चुकी है। दैट मे बी अ राइट, दैट मे बी अ रॉन्ग, बट आपके फाइनेंशियल गोल पूरे करने के लिए क्या वो पैटर्न सही रहेगी या गलत रहेगी, वो आपको कैसे पता चलेगा? राइट, इसीलिए ओपीडी बहुत ज़रूरी है। और ये कैसे करनी है उसका मैं एक छोटा सा प्रेजेंटेशन दूंगा। 10 मिनट का प्रेजेंटेशन है। उसके बाद आप सबको पेपर मिला है? यस और नो? पेपर नहीं मिला है? यस। तो ये पेपर पे आपको एक एक्सरसाइज कराऊंगा। राइट, मोस्ट ऑफ यू फील कि यार ये एक्सरसाइज क्या है, बट उसका मैं रियलाइजेशन आपको कराऊंगा ये क्यों इंपॉर्टेंट है। ठीक है? Why OPD? Doctor earns well, but assessment matters more. Family financial goal assessment. हम इन्वेस्टमेंट क्यों करते हैं? Why we are investing? रिटर्न कमाने के लिए। एवरीबडी इज थिंकिंग मैं रिटर्न कमाने के लिए कर रहा हूं। एक्चुअली रिटर्न किसी को समझ में नहीं आता है। मैं आपको एक ही क्वेश्चन करता हूं, जिसको रिटर्न समझ में आता है वो मुझे एक कैलकुलेशन बताए। 1 लाख रुपया 15% के हिसाब से 30 साल में कितना बनेगा? आपको कैलकुलेटर की जरूरत पड़ेगी। आप समझ गए? बट इसका इजी वे भी होता है, रिटर्न किसी को नहीं समझ में आता है। सबको ऐसा लगता है कि मेरा बिजनेस ही सबसे बड़ा है, मेरा प्रैक्टिस इज माय इनकम। बट एक बात समझ लो, एक दिन आपकी प्रैक्टिस खत्म होने वाली है। वो प्रैक्टिस जैसे खत्म होगी, आपके पास प्रैक्टिस की इक्विवेलेंट का मंथली अमाउंट कैसे आएगा? क्या आपने उसका प्लानिंग किया है क्या? दैट इज द इंपॉर्टेंट पार्ट, राइट? आप मरते दम तक प्रैक्टिस करोगे। डॉक्टर ऑलवेज से कि यार मेरा तो क्या है, मेरे बाजू में घर है, बाजू में क्लिनिक है, मैं तो मरते दम तक प्रैक्टिस करूंगा। बट एक एज के बाद आपको प्रैक्टिस पैसे के लिए नहीं करनी है, और वो कभी होगा जब भी आपके पास सेकेंड सोर्स ऑफ इनकम होगा, तब तक ये नहीं होगा। बट इट्स अ वेरी वेग स्टेटमेंट, सेकेंड सोर्स ऑफ इनकम। देखो, एक लाइफ का गोल बन गया। मैंने अभी गोल की बात करी, लाइफ का एक गोल बन गया। वैसे बहुत सारे गोल एज अ डॉक्टर्स हो सकते हैं, राइट? मैं भी जब भी हमारे पास क्लाइंट्स आते हैं, डॉक्टर आशय जी ने जो बताया ना, वो हम लोग एक्चुअली प्रैक्टिस करते हैं, बिकॉज उनकी बातें सुनकर हमको हमारी रिस्पॉन्सिबिलिटी समझ में आई। बिकॉज जब भी हम लोग मेडिक्लेम देते हैं तो पेशेंट यानी कि जो कस्टमर है वो खाली प्रीमियम पे फोकस करता है कि भाई इसका प्रीमियम 40,000 है, इसका प्रीमियम 35,000 है, तो मैं 35,000 लेता हूँ, 40,000 नहीं लूँगा। और जब भी वो हॉस्पिटल में जाता है तो वही पेशेंट एक्सपेक्ट करता है कि भाई मेरा बिल 8 लाख की जगह पे 6 लाख आना चाहिए। यानी जब भी डिसीजन लिया था, और जब भी अच्छा बिल के लिए जो माथा पच्ची कौन करता है, उसका फैमिली मेंबर। जो फैमिली मेंबर कभी भी इन्वॉल्व नहीं था डिसीजन में कि मैं ये प्रोडक्ट लूँ कि नहीं लूँ, और आज वो आके हमको बोलता है कि भाई, डॉक्टर्स को बोलता है कि भाई तुमने पैसा ज़्यादा लिया, ठीक है? तो ये चीज़ बहुत इंपॉर्टेंट थी। अल्टीमेटली कोऑर्डिनेशन बहुत इंपॉर्टेंट है। हमको यानी कि हमको हमारी रिस्पॉन्सिबिलिटी समझ में आ गई है कि भाई मेडिक्लेम देने से पहले हमको ये अवेयर करना है कि भाई जो भी कुछ कर रहे हो, ब्लेम डॉक्टर्स को कर रहे हो, ये गलत है। ऐसा नहीं होता है। आपने जब भी डिसीजन लिया था तभी पैसा देखा था, आपने जब भी पॉलिसी लिया था तभी प्रीमियम देखा था, आपने जब भी पॉलिसी लिया था तभी फीचर्स नहीं देखा था, और अभी डॉक्टर्स को ब्लेम कर रहे हो। गलत चीज़ है, राइट? सो इट्स अ मैटर ऑफ अवेयरनेस, और हम दोनों को साथ में एज अ कम्युनिटी, एज अ डॉक्टर कम्युनिटी एंड फाइनेंशियल एडवाइजर कम्युनिटी, ये दोनों को साथ में मिलकर करनी पड़ेगी। बिकॉज इट्स अ अवेयरनेस जो इंडिया में ज़रा भी नहीं है, राइट? हमारे सब्जेक्ट में फाइनेंस जैसा कुछ था ही नहीं, हमारे सब्जेक्ट में फाइनेंस था ही नहीं। हमको खाली सिखाया गया था कि लाख रुपया कमाने का कैसे, बट लाख रुपया हाथ में आया तो उसको मैनेज कैसे करने का वो किसी को नहीं समझ में आता है। ना कोई इंस्टीट्यूट ने सिखाया था, ना कोई सिखा रही है, राइट है? इसीलिए बच्चे आज देखो क्या हो रहा है, 20 ईयर्स का बच्चा, बराबर है, वो क्रिकेट का ऐप कौन सा है? ड्रीम 11, राइट है? ड्रीम 11 में 20 करोड़ सब्सक्राइबर है। इतने सारे मेहनत के बाद म्यूचुअल फंड में खाली 5 करोड़ इन्वेस्टर है। आप समझ गए हो? यानी बच्चा, आपका बच्चा अगर यंग है तो उसके मोबाइल का ऐप चेक करो, कौन से ऐप है उसके पास, आपको समझ में आ जाएगा उसका एजुकेशन लेवल किधर है, राइट है? बट वो नहीं करते हैं बिकॉज हमको वहाँ पे जाना नहीं है, क्योंकि हम लोग क्या बोलते हैं, बच्चे हमारा सुनता ही नहीं है। सीधा जवाब दे देते हैं, बच्चे हमारा नहीं सुनते हैं, राइट? बच्चे को कभी आपने साथ में लेके बात किया होगा तो वो सुनेंगे, वरना वो यूट्यूब से नॉलेज ले लेंगे, ठीक है? तो ये बहुत इंपॉर्टेंट पार्ट था। फैमिली फाइनेंशियल गोल ऑब्जेक्टिव क्या होता है, व्हाई वी नीड अ फैमिली फाइनेंशियल गोल होता क्या है? देखो, गोल प्लानिंग बहुत सब करते हैं, बहुत सारे होते हैं, सबके दिमाग में गोल्स है, बट वो दिमाग में है, पेपर पे कोई नहीं होता है। आशय सर ने बताया, मैं जो भी कुछ करता हूँ वो पेपर पे लिखता हूँ, और पेपर इज अ रिटन डॉक्यूमेंट, यू आर ऑथेंटिकेट टू समवन। आपने अपने लिए फाइनेंशियल गोल बनाए हैं, क्या वो पेपर पे लिखे हैं क्या? मैं गारंटी के साथ बोल सकता हूं 90% लोगों ने अपने फाइनेंशियल गोल पेपर पे नहीं लिखे हैं। जो भी कुछ है वो यहां पे है, राइट है? जिसके लिए आप मेहनत कर रहे हो, खाने के लिए 2 ही रोटी खाते हो बॉस, बट ये जो प्रेस्टीज, ये जो मेंटेन करने के लिए जो मेहनत हो रही है ना, वही गोल आपने पेपर पे लिखे नहीं है। मेरा काम है वो पेपर पे लिखवाना, राइट. सो यू आर ऑथेंटिकेट टू डू दैट. ये कैसे होगा ये भी मैं आपको डेमो के साथ बताऊंगा. राइट. बेनिफिट ऑफ फाइनेंशियल गोल असेसमेंट. क्या बेनिफिट होता है, यानी कि ये टॉपिक क्या क्या है मैंने लिया हुआ है. फैमिली फाइनेंशियल गोल्स, शॉर्ट टर्म क्या क्या गोल्स होते हैं, शॉर्ट टर्म गोल्स, लॉन्ग टर्म, मिड टर्म गोल्स, लॉन्ग टर्म गोल्स, स्मार्ट फाइनेंशियल गोल्स क्या होते हैं. फैमिली फाइनेंशियल गोल यानी क्या, आप कहाँ पे हो, गूगल मैप ओपन करते हो ना, आप कहाँ पे हो, आपको कहाँ पे पहुँचना है. आपने जब भी गूगल मैप ओपन किया तो गूगल मैप पहला क्वेश्चन क्या करता है, आप कहाँ पे हो, देखिए कहाँ पे जाना है, करंट लोकेशन. एग्जैक्टली. फैमिली फाइनेंशियल प्लानिंग का पहला डेस्टिनेशन है, पहले आप डिसाइड करो पहले आज आप कहाँ पे हो. राइट है. और बाद में सेकंड होता है कहाँ पे जाना है. हम तो पहले क्या बात करते हैं, भाई कितना रिटर्न देता है बता, इसके अलावा कोई बात नहीं करते. राइट. ठीक है. सो दिस इज इंपॉर्टेंट पार्ट. बेनिफिट ऑफ फाइनेंशियल गोल असेसमेंट का मतलब क्या है, फाइनेंशियल सिक्योरिटी, अ सेफ्टी, नॉट अनएक्सपेक्टेड एक्सपेंस. बिजनेस, किसी का बिजनेस है, किसी ने रेडियोलॉजी सेंटर खोला हुआ है, अनएक्सपेक्टेड एक्सपेंस कितने आ सकते हैं, क्या हमने उसको बजटिंग किया है क्या. दैट इज द इंपॉर्टेंट पार्ट. कैसे हम बजट करते हैं, कैसे आप जो डेली का कैश, यानी अगर समझो कि डेली जिसके पास कैश ज़्यादा है उसके लिए करंट अकाउंट कैश मैनेजमेंट सिस्टम है क्या. राइट है. क्या आपने सुना है करंट अकाउंट कैश मैनेजमेंट सिस्टम. करंट अकाउंट में कितना इंटरेस्ट मिलता है, एनीबॉडी, कितना, 0. परफेक्ट है. बट वो करंट अकाउंट से आप पैसे कमा सकते हो. अगर वो स्ट्रेटेजी आपको जाननी है तो एक बार हमसे कंसल्ट कर लेना. मैं आपको बताता हूँ ये स्ट्रेटेजी कैसे बनती है. एक रेडियोलॉजिस्ट जिसकी 3,30,00,000 की महीने का कलेक्शन था, हमने ये एक्टिविटी करी थी, साल में 4 लाख रुपया करंट अकाउंट से बन गया था. शायद एक ड्राइवर की फीस निकल गई थी. राइट. बट वी हैव टू अंडरस्टैंड दिस कि भाई ये कैसे हो सकता है. वी हैव टू प्लान दिस. सिक्योरिटी, अचीविंग योर ड्रीम्स, बिल्डिंग वेल्थ, पीस ऑफ माइंड एंड फाइनेंशियल इंडिपेंडेंस के लिए आपको ये एक्टिविटी करनी पड़ेगी. राइट. जैसे आप कोई भी बड़ा काम करते हो ना, देखो आप घर बनाते हो ना तो आर्किटेक्ट डिज़ाइन करते हो, आर्किटेक्ट रखते हो, हायर करते हो. आर्किटेक्ट एक प्लान बनाता है, वो ऐसा बोलेगा क्या, मेरे दिमाग में सब है, लाइट इधर रहेगी, ये दीवार पे ये कलर रहेगा, आप अभी उसको इमेजिन कर लो. ऐसा होगा, चलेगा क्या, यस और नो. नहीं. आपने कभी आपके फाइनेंशियल गोल को पेपर पे डिजाइन किया है, कभी नहीं. इंडिया का बजट देखने में पूरे दिन हम लगा लेते हैं. इंडिया ने क्या किया बजट में, आपने खुद का ईयरली बजट बनाया क्या, आपने अपने मंथली कैश फ्लो को कभी चेक किया है, कभी पेपर पे लिखा है क्या. हमारी गुजराती में कहावत है, लखे एनु घर वसे. राइट. बट लिखना तो हम भूल ही गए हैं कि भाई कभी हमने लिखा नहीं है. राइट. तो ये सब चीज वी आर डूइंग वेरी सिंपल थिंग. हम लोग कोई हाई फाई प्रोडक्ट की बात नहीं करते हैं, बट जो सिंप्लिसिटी है उससे पैसा कैसे बन सकता है, दैट्स व्हाट वी आर डूइंग. टाइप ऑफ फाइनेंशियल गोल्स, वेल्थ क्रिएशन, रिटायरमेंट, ये सब कॉमन बात करते हैं. राइट है. वेल्थ प्रोटेक्शन गोल, डेथ, डिजीज, डिसेबिलिटी. राइट. जब भी मैं डॉक्टर्स को पूछता हूँ ना, आपके पास मेडिक्लेम कितना है, बोलते हैं हमको क्या ज़रूरत है, हमारे पास फ्रेंड है ना, वो इलाज करवाएगा. बट क्या 1 करोड़ का खर्चा आएगा तो क्या मुफ्त में इलाज होगा क्या. राइट. कितने डॉक्टर्स यहाँ पे है जिसका 1 करोड़ का मेडिक्लेम है. दिस इज द फाइनेंशियल अवेयरनेस. आपको पता है आपके फील्ड में मेडिकल कॉस्ट कितनी बढ़ गई है, बट 1 करोड़ का मेडिक्लेम नहीं है हमारे पास. राइट. तो इसीलिए बहुत ज़रूरी है, एक एडवाइज़र होना बहुत ज़रूरी है आप लोगों के पास. ओके. वेल्थ प्रोग्रेशन, आपने जो पैसा बनाया वो नेक्स्ट जनरेशन को कैसे अच्छी तरह पहुँचे. अगर नेक्स्ट जनरेशन NRI है तो NRI का वो हैजल फ्री पैसा जाना चाहिए, उसका आपको बंदोबस्त करना पड़ेगा, उसकी तैयारी आपको करनी पड़ेगी। आप ये नहीं बोल सकते हो कि भाई मैं तो अपनी लाइफ जी लिया, उनको जो करना है वो करेंगे। आप ये नहीं कर सकते हो, ठीक है। सो ऑब्जेक्टिव, गोल प्लानिंग का 3 फेज होते हैं, ऑब्जेक्टिव, कॉर्पस एंड होराइजन। ये 3 ही चीज होती है जो आपको उसके लिए आपको ब्रेनस्टॉर्मिंग करनी है। आपको ये बहुत इजी लगता है, बट जिस दिन आप सामने बैठते हो, आपका काउंटर क्वेश्चन होता है, तो आपको समझ में आता है कि ये एक्टिविटी कितनी डिफिकल्ट है। 90% लोग प्लानिंग ही नहीं करते हैं, और इसीलिए नहीं करते हैं क्योंकि बहुत सारे क्वेश्चंस आते हैं और क्वेश्चन को उसको फेस नहीं करना है, और वो फेस नहीं करना है, इसीलिए प्लानिंग नहीं होता है और वो पूरा मैशअप होता है। प्रोडक्ट कोई भी खराब नहीं होता है, कोई भी कंपनी प्रोडक्ट निकालती है वो खराब प्रोडक्ट नहीं निकालेगी, बट एवरी प्रोडक्ट इज मेंट फॉर सम कैटेगरी ऑफ द पीपल। आप क्या वो कैटेगरी, ये प्रोडक्ट आपके लिए सूटेबल है, वो आप कैसे डिसाइड करोगे? ये इंपॉर्टेंट पार्ट है फाइनेंशियल प्लानिंग का, गोल का। अभी जैसे मैं एक सिंपल चीज बताऊं, नाउअडेज AIF इज अ वेरी पॉपुलर, आउटबाउंड AIF, यानी कि जो कंपनी इंडिया के बाहर US, सिंगापुर, चाइना की कंपनियों में पैसा डालती है, बराबर है, तो ये हमारे लिए, ये कौन से गोल के लिए इंपॉर्टेंट होगा? जो पेरेंट्स अपने बच्चे को US में एजुकेशन देना चाहता है, उसके लिए ये प्रोडक्ट सही है। क्यों? क्योंकि इसके सामने वो डॉलर का हेजिंग करते हैं। इट इज़ नॉट फॉर रिटर्न, इट इज़ अ हेजिंग विद द डॉलर। इसीलिए ये प्रोडक्ट उन पेरेंट्स के लिए अच्छा होता है जिनको ड्रीम है कि मेरा बच्चा US में जाके MS करे। तो देयर इज अ लॉजिक बिहाइंड एवरी प्रोडक्ट। वी हैव टू अंडरस्टैंड मेरे लिए क्या सही है, और उसके लिए आपको अपने फाइनेंशियल एडवाइजर के साथ बैठना पड़ेगा, राइट है। यहां पे कौन हस्बैंड वाइफ साथ में है? हस्बैंड वाइफ, राइट है। चलो एक ही जन है। अभी मैं दूसरा क्वेश्चन थोड़ा ट्विस्ट कर लेता हूं, ठीक है। क्या आपके स्पाउस को, स्पेसिफिकली हस्बैंड जो फाइनेंस मैनेज करते हैं, आपकी वाइफ के पास आपके फाइनेंशियल एडवाइजर का नंबर है क्या? आपकी वाइफ ने कभी आपके फाइनेंशियल एडवाइजर से बात करी है क्या? आपको कुछ हो गया तो वो किस पे ट्रस्ट करेगी? और पैसा एक ऐसी चीज है, जिस दिन पता चला कि भाई इनके पास पैसा आने वाला है, जो नजदीक नहीं आते वो भी आने चालू हो जाते हैं, राइट। इसीलिए फैमिली फाइनेंशियल डॉक्टर होना भी उतना ही जरूरी है जितना फैमिली डॉक्टर होना जरूरी है। आप समझ गए? ये बहुत इंपॉर्टेंट चीज है। इट इज नॉट अबाउट, देखो आप कोई भी प्रोडक्ट लोगे, मुझे तो इनकम बननी है, बट अगर मैंने आपको सुटेबल प्रोडक्ट दिया तो आपको ये कभी तकलीफ नहीं आएगी कि ये बंदे ने मेरे प्रोडक्ट से पैसा कमाया था, क्योंकि मैं आपसे इलाज लेता हूं तो आप मेरे से फीस लेते हो। मैं कभी ये नहीं बताता हूं कि बॉस मेरी फीस से आपने पैसा बनाया है, आपने मुझे अच्छा किया, मेरा पर्पस सॉल्व किया। मैं आपके फाइनेंस का, आपकी फाइनेंशियल लाइफ का पर्पस सॉल्व कर सकता हूं, इसकी मैं फीस लेता हूं, राइट। तो मुझे चैट GTP से कोई डर नहीं है। चैट GTP, डायरेक्ट प्लान, उससे कोई फर्क नहीं पड़ता है। अगर डायरेक्ट प्लान, अगर इन्वेस्टर को ये समझ में आता तो आप 20-30 साल पहले SIP कर चुके होते, और यहाँ पे जो मैं पेपर पे रिटर्न दिखाता हूँ ना, वो यहाँ पे हर सीनियर सिटीजन के पास होता, बट नहीं है किसी के पास। दैट्स व्हाई यू रिक्वायर्ड अ फाइनेंशियल एडवाइजर, राइट। ओके, सो दिस इज इट। ऑब्जेक्टिव ये था। टाइप ऑफ वेल्थ क्रिएशन, गोल्स क्या क्या हो सकते हैं, मैं डॉक्टर्स के रिलेटेड ही बात करूंगा। शॉर्ट टर्म गोल्स, मीडियम टर्म गोल्स एंड लॉन्ग टर्म गोल्स। शॉर्ट टर्म गोल्स में क्या हो सकता है? आपको क्लिनिक करना है, आपको घर लेना है, बराबर है, तो घर के लिए आपको कॉर्पस यानी कि डाउन पेमेंट के लिए पैसा करना है। घर लोन से लेना है कि नहीं लेना है? लोन लेनी है तो कितना टका इनकम का लोन लेना चाहिए ताकि फिनेंशियल स्ट्रेस नहीं आए? आपने अगर लोन ले लिया तो चुकाना चाहिए कि नहीं चुकाना चाहिए? हाउसिंग लोन लिया है तो कभी मत चुकाओ। इंडिया में सबसे सस्ता लोन हाउसिंग लोन है। आपको इंडिया में 7.5% से कौन पैसा देगा, वो भी 20 साल के लिए। आप बिजनेस के लिए पैसा मांगने जाते हो तो आपको 10% 12% चार्ज करता है, और जो हाउसिंग लोन आपको 7.5% में पैसा दे रही है उसको 5 साल में कंप्लीट करने का यानी कि उतावले होते हो। उससे खाली एक ही चीज को, एक ही जन को फायदा होता है, बैंक को। आपको पता है बैंक की वो साइकिल, वो 20 साल की जो साइकिल है वो 4 बार घुमाता है, बिकॉज ऑफ आवर मेंटेलिटी। यानी उसकी प्रॉफिटेबिलिटी चार गुनी बढ़ गई, इसीलिए बैंक के स्टॉक्स बढ़ते हैं, राइट, बिकॉज ऑफ आवर मेंटेलिटी। ठीक है, तो ये सब चीज है। अगर आपका प्लानिंग है बड़ा हॉस्पिटल करने का तो उसके लिए कॉर्पस जमा करना पड़ेगा। अगर आपका प्लानिंग है कि चैरिटी करना है, उसके लिए भी आपको मंथली इनकम की जरूरत पड़ेगी, कि आपका इनकम बंद हो जाए उसके बाद ये अमाउंट मैं चैरिटी को दूंगा, उसके लिए भी आपको कॉर्पस की जरूरत पड़ सकती है। गोल इज एवरीवेयर, बट हमने कभी किया नहीं है, राइट, क्योंकि वो बहुत मुश्किल है ना, क्वेश्चन आंसर करते हैं, राइट, और क्यों करना है, और पूछेंगे शायद अगर नहीं हुआ तो नहीं हुआ, ठीक है, बट मैंने ट्राई तो किया अल्टीमेटली, राइट। तो ये सब चीज इंपॉर्टेंट था। गोल्स क्या कैसे होने चाहिए, इट शुड बी स्मार्ट, स्पेसिफिक, मेजरेबल, अचीवेबल, रिलेवेंट एंड टाइम बाउंड। कैसा एग्जाम्पल दिया है मैंने, देखो एग्जाम्पल ऑफ स्मार्ट गोल। डॉक्टर राहुल गुप्ता, एज 35, स्टार्टेड हिज डायग्नोस्टिक सेंटर इन बोरीवली, बराबर है। अभी उसके गोल क्या हो सकते हैं, एज्यूम करो, बिल्ड अ कॉर्पस ऑफ 3 CR by 2030 to repay amount to bank and close the loan. Yes or no? Relevant? राइट है। कैसे, अब अगर किसी का नाम राहुल गुप्ता होगा तो भाई कोइंसिडेंस है ऐसा। स्पेसिफिक कि भाई किसके लिए बनाना है, कॉर्पस बिल्ड करना है लोन पे के लिए, कभी करना है, कितना करना है, 3 करोड़, बराबर। अचीवेबल है, मैं कैश फ्लो से पता चलेगा मेरी इनकम कितनी है, मेरा एक्सपेंस कितना है, मैं कितना साइड पे कर सकता हूं ताकि मेरा ये 5 साल में हो सके, बराबर। तो अचीवेबल है, वो कैसे पता चलेगा, मैंने कैश फ्लो किया तो समझ में आएगा, वरना नहीं आएगा। मेंटल अकाउंटिंग से कुछ नहीं होगा, आपको समझ में नहीं आएगा कहां पे गलती हो गई, राइट। एंड रिलेवेंट होना चाहिए, लोन पे करना है तो मैं दूसरा रेडियोलॉजी सेंटर कर सकूं, मुझे बढ़ाना है तो मैं कर सकूं, राइट है। डेंटिस्ट है तो मुझे एक चेयर, डेंटिस्ट के लिए क्या इंपॉर्टेंट होता है, चेयर्स, 1 चेयर, 2 चेयर, 3 चेयर। तो क्या आपने गोल बनाया है क्या कि भाई मुझे 3 चेयर के लिए ये प्लान करना है, राइट। तो ये प्लान लिखा होगा तो आप उसको फॉलो कर पाओगे। तो ये जस्ट मैं एग्जाम्पल दे रहा हूं जो मुझे अभी समझ में आ रहा है, राइट, बिकॉज लॉट ऑफ डॉक्टर्स आर माई क्लाइंट, तो मैं उसकी अंडरस्टैंडिंग, मैं उनकी रिक्वायरमेंट अंडरस्टैंड करता हूं कि भाई क्या है उनकी रिक्वायरमेंट, एक्चुअली रिटर्न के अलावा उसकी रिक्वायरमेंट क्या है, ठीक है। सो दिस इज इंपॉर्टेंट एंड टाइम बाउंड, 5 साल में ये कंप्लीट होना चाहिए। देखो टाइम बाउंड था, राइट है, ये पॉसिबल है, यस है। उसको ट्रैक कैसे कर सकते हैं, देखो अगर ये स्क्रीन पे आप देखोगे, दिस इज माय फाइनेंशियल गोल, मुझे अगले 15 साल में ये 2039 100 करोड़ बनाना है, कितने, दिस इज माय फाइनेंशियल गोल। मैं अपनी बात करूंगा, दूसरा किसी की बात नहीं करूंगा। मेरी मंथली एसआईपी जा रही है कितनी, 5 लाख रुपया, राइट है। अगर ये स्पीड से मेरा गया, मैं 49 करोड़ बनाऊंगा। अगर मुझे 100 करोड़ बनाना है तो मुझे स्पीड बढ़ानी पड़ेगी, बट मेरे दिमाग में है, अभी कोई भी प्रपोजल मेरे पास आता है तो मेरे दिमाग में एक ही प्रपोजल है, ये मेरा प्लान है, मुझे यहाँ से डिस्ट्रैक्ट नहीं। अगर ये मैंने प्लान नहीं बनाया और कल आशीर्वाद मुझे मिल गए, अरे नेहल ये अच्छा प्रपोजल है, चल करते हैं, तो मैं उधर जुड़ जाऊँ। और 99% लोग ऐसे ही करते, पैसा एंड पानी दोनों है टू सेम कैरेक्टरिस्टिक। अगर आपने कमाए हुए पैसे को ये नहीं बताया कि तुझे किधर जाना है, वो किधर भी चला जाए, राइट है। आपने बारिश गिरती है मुंबई में, रिजर्वायर के बाद यानी कि कांता प्रवाह में गिरती है तो वो हमको पूरे साल पानी देती है। अगर वो बोरीवली में गिरेगी तो वो दोहराई को खत्म नहीं करेगा, राइट। बारिश तो सेम है, बट आपने अपने कमाए हुए पैसे को बता दिया कि इधर जाना है, वो उधर ही जाना है, वो किधर नहीं, राइट। इसीलिए गोल इंपॉर्टेंट है। आपने दूसरा नोटिस किया होगा, यहाँ पे मेरा एडवाइजर अलग है। A best of the best doctor cannot operate himself. What I am preaching, I am practicing. मेरा एडवाइजर अलग है। आज भी मैं फाइनेंशियल डिसीजन लेने से पहले मैं उसकी एडवाइस देता हूँ। वो मेरा हर साल कैश फ्लो करता है, मेरा रिस्क एनालिसिस करता है, उसके बाद ही वो डिसीजन लेता है। चाहे वो मेरा घर का डिसीजन हो, चाहे वो मेरा ऑफिस लेने का डिसीजन हो, कोई भी डिसीजन, राइट। तो दैट इज इंपॉर्टेंट पार्ट, व्हाट आई एम टीचिंग, आई एम प्रैक्टिसिंग, राइट। और गोल प्लानिंग का सिस्टम कैसा होना चाहिए उसका मैंने एक एग्जांपल दिया है। ये देखो कि भाई ये एक क्लाइंट का एग्जांपल है, उसको होम परचेज के लिए 5.5 करोड़ का गोल बनाना था 2027। देखो ये मैच्योरिटी पे आने वाला है, उसने एसआईपी कितनी करी है 3.55। क्या ऐसा कोई सिस्टम आपके पास अवेलेबल है कि खाली मेंटल अकाउंटिंग है, राइट? क्या आपको लगता है ऐसा कोई सिस्टम होगा तो आपको पीस ऑफ माइंड मिलेगा? अगर यस तो हमको हमें कांटेक्ट करना। वी हैव अ 20 पीपल टीम, आपके ऑफिस में, आपके क्लिनिक पे आके आपको समझाएंगे आपकी अभी की पोजीशन क्या है, आपको कौन सा गोल अचीव करना है, ये सब हम हेल्प करते हैं। और इसके लिए देखो मैंने आपको एक एक्सरसाइज दी है। आपके पास सबके पास पेपर है? यस और नो? भाई टाइम हो गया? हाँ ओके। सो देखो यहाँ पे मैंने लिखा है इमरजेंसी फंड, चाइल्ड एजुकेशन प्लान। बहुत जन के साथ ये रिलेटिव नहीं होगा, बट आपके नेक्स्ट जनरेशन के साथ शायद हो सकता है। ओके, थिंक विथ योर नेक्स्ट जनरेशन ऑल्सो कि भाई इसके रिलेटेड है क्या, ये आपके रिलेटेड है, वो प्लान आप टिक करो। आपके पास ऐसा कोई मेजरमेंट है क्या कि भाई आपका कोई गोल है जो मैंने चालू है, मुझे मंथली इनकम चाहिए, तो वो पीसफुली आ रही है कि नहीं आ रही है, राइट? कि मैं आज भी क्लिनिक पे, आज भी मैं रिटायरमेंट के बाद मैं क्लिनिक की इनकम पे डिपेंडेंट हूँ। अगर ये है तो आपने अपना रिटायरमेंट प्लान नहीं किया है। मोस्ट ऑफ द टाइम आपके पास यू आर एसेट रिच, आपके पास एसेट है, कैश नहीं है, राइट? देयर इज अ डिफरेंस बिटवीन एसेट रिच एंड कैश रिच। यहाँ पे अगर मैं ऑब्जर्वेशन लेता हूँ, मोस्ट ऑफ द टाइम डॉक्टर्स आर एसेट रिच, बट आप कैश रिच हो, वो आपको आइडेंटिफाई करना है और उसके लिए एक्सरसाइज करनी पड़ेगी, राइट? ओके, सो दिस इज इंपॉर्टेंट थिंग। एम आई मेक अ सेंस? यस और नो? यस। सो दिस इज इंपॉर्टेंट पार्ट। ये पेपर आपकी एक्सरसाइज के लिए है, आपके पास ही रहेगा, आपको किसी को देने की जरूरत नहीं है। बट अगर आप ये एक्सरसाइज करते हो, आपको रियलाइज होएगा आपको एक फाइनेंशियल डॉक्टर की जरूरत है या नहीं है, राइट? इट इज नॉट अबाउट रिटर्न मेरे कंट्रोल में नहीं है, ना मैं कभी उसको प्रॉमिस कर सकता हूं। जैसे आप पेशेंट को दवाई देते हो, ठीक होना आपके कंट्रोल में नहीं है। आपके पास खाली एक ही चीज है, पीछे का एक्सपीरियंस कि भाई ये दवाई से बहुत लोगों की जान ठीक हुई है, आपकी भी हो जाएगी। कल कुछ आगे पीछे हुआ उसका हमको समझ में नहीं आता है। सेम विथ इन्वेस्टमेंट ऑल्सो। देखो, आई एम अ एडवाइजर, आई एम नॉट अ मैन्युफैक्चरर। जैसे मैं आपके पास कोई पेशेंट आता है तो आप सिप्ला का दवाई लिख के देते हो, एग्जाम्पल, तो क्या सिप्ला का दवाई आप बनाते हो क्या? बराबर है। बट फिर भी पेशेंट क्या बोलता है, मुझे ये डॉक्टर ने ठीक करके दिया, ये डॉक्टर ने मुझे ठीक करके दिया। द सेम चीज यहां पे है। आई एम नॉट अ मैन्युफैक्चरर। HDFC म्यूचुअल फंड कल क्यों अच्छा है, टाटा म्यूचुअल फंड क्यों अच्छा है, मोतीलाल ओसवाल क्यों अच्छा है, राइट है? ये हमारे कंट्रोल में नहीं है। हमारे कंट्रोल में है आप अपना कैश फ्लो संभाल के रखो, आप अपना गोल प्लानिंग करो, आप अपनी रिस्क एपेटाइट को संभालो, जो आने वाली रिस्क है उसको मिटिगेट करोगे और उसको पेपर पे लिखोगे तो हमको मिटिगेट करने का प्लान होगा, और अगर वो प्लान होगा तो आप उसको टैकल कर पाओगे. विद दैट, थैंक यू वेरी मच. I hope I have make a sense for you. Thank you very much.
Thank you. I request Dr. Manish Jain to felicitate Mr. Nehal Parekh. I request Dr. Lata Mehta to introduce our next speaker.
Wait. Ma'am, Lata ma'am, just a minute. Before we proceed, we'd like to thanks and welcome on stage our gold sponsor, Dr. Amit Gangwani from Heart and Vascular Super Specialty Hospital. Dr. Amit, please. I request President Dr. Paresh Mehta, BMB Secretary Dr. Meenal Panchal, Organizing Chairman Dr. Ashish Modi, Convener Dr. Shai Bangera, Organizing Secretary Dr. Kinjal Modi. Yeah, please, sir. Please join us on stage, Dr. Jignesh Mehta. Please. Yes. Thank you, sir, for this wonderful support to BMB MEDIMEET 2026. Thank you, and thanks for coming with us. How was your experience with us?
I think this is the way the annual conference should be, to be very honest. It has to, so the purpose of annual conference is to meet and greet. That was the first day. You interact, you know about different people. Second, once you leave your work behind, I think you're stress-free, and that yesterday evening wala session was very, very amazing. So,
Huge round of applause for Dr. Amit, sir, from Heart and Vascular Super Hospital. How many have visited HVS? आपने सारे visit किया HVS को? अच्छा, जिन्होंने नहीं किया, they have to go and visit HVS. Sir, they will be your guest. Thank you, sir. Thank you. So, thank you, sir. Lucky draw कर लेते हैं. Okay. किसको लकी ड्रॉ कल मिला है? रेज योर हैंड. एक, बाकी 2, 3, 4, 5, 6 जन को 7 लकी ड्रॉ. 6 सेशन तो 10 थे, बाकी के 4 किधर गए? 7, 8 बाकी के 2 किधर गए? आपने आज कूपन डाले सबने? किसी का बाकी कूपन डालने का? राइट. सो आई हैव okay. How many of you have iPhone? iPhone. Okay. So next lucky draw gift is for them who has iPhone. तो जिस एंड्रॉयड वाले को मिलेगा आईफोन वाले को दे देगा. सेटिंग करके रखो फटाफट. चलो सब टेबल पे एक आईफोन वाला रहेगा. सब लोग सेटिंग करो. तो लकी जो वो टेबल का लकी ड्रॉ गिफ्ट गया तो आईफोन वाला घर पे लेके जाएगा. राइट. ओके. सो मेरे पास भी आईफोन है. हम दोनों के इधर दे, हम दोनों को दे. आशीष सर, ऐसा गिफ्ट नहीं लाने का. तो मैंने वही बोला ना, जो टेबल पे जाएगा आईफोन वाला घर पे लेके जाएगा. ओके. And the gift is supported and sponsored by Glennon Healthcare, and lucky one is ले. दो जिग्नेश सर. डॉक्टर आशीष मोदी लिखा है इसमें. आईफोन नहीं है तो हमारा ना. ओके. द लकी वन इज डॉक्टर हरीश तिवाड़िया. आईफोन है दिखाओ. हाँ, वाह, गिफ्ट वर्थ हो गया. थैंक यू. इससे जीपीएस ट्रैकर. अभी सर अपने पॉकेट में मत रखना, लफड़ा हो जाएगा. बाइडी ट्रैक करेगी फिर. सेकेंड वन 2 देने का है. मैंने 2 डिक्लेयर किया है. और एक એટલે બચી ગઈ. જો તમને આવ્યું, જો પ્રાર્થના કરી તો મળી ગયો. इंस्टेंट कर्मा છે આ. मेरा ही नाम निकलना चाहिए. पहले बता रहा हूँ देखो. शेट ये गिफ्ट तो मैं ही लेगा, ये गिफ्ट तो मैं लेगा.
कल इनका मिस हो गया था, आज नाम निकला है वापिस. डॉक्टर मनोज रामगुड़े आज बर्थडे है.
क्या लेके रहे हैं? ए भाई इंसान देख के गिफ्ट आया रे. एक क्लिनिक पे काम पर हाउस है. अवंती, over to you.
I request Dr. Lata Mehta to introduce our next speaker.
So we welcome Dr. Lata Mehta, our first lady, to introduce our next speaker.
Good morning, everyone. I welcome Dr. Rohit Barnabas. Dr. Rohit Barnabas is a MBBS MD in General Medicine, DM endocrinologist, currently positioned as an associate professor in Department of Endocrinology, Metabolism State at GS Medical College and KM Hospital, Mumbai. Clinical expertise: diabetes mellitus, thyroid, pituitary and parathyroid disorders, reproductive endocrinologist, obesity and metabolic bone disease, adult and pediatric endocrinologist. Awards: A.V. Gandhi Award, Endocrine Society of India 2022, Dr. S.B. Bhandarkar Award for the Best Resident in DM Endologist, AR-SAID Award, Endocrine Society for India 2024. More than 43 publications in national and international peer-revised journal. I welcome Dr. Rohit Barnabas.
Yeah, thank you, ma'am, for the kind introduction. So I thank the organizers for giving me this opportunity. So they've given me a very interesting topic, andropause, is it a reality? Now, I'll be very brief, unlike the other speakers, so that you can grasp the details of this. See, now we understand menopause. Menopause, we know, is an event which happens in every lady's life, and it is a well-defined event. Okay, it's a well-defined event, and you know that suddenly there is non-functioning of ovaries, and women go through that phase, and they live through that phase for many years, because now longevity is increasing. The andropause goes on, so menopause starts at 51, and then, I mean, if the lady is living till 90, 100, so another half of the life lady is living in menopause. Now what about andropause? Is it a reality? Now we have come to understand as endocrinologists that men also start developing lowering of serum testosterone with aging. But the problem with andropause is it's not a clearly defined event. Like menopause, you know, one day you're getting cycles and next day you don't have. It's a very clearly defined event, whereas andropause is a slow and gradual process with testosterone declining. Now why this topic is given, why it is relevant? Now we know a lot of general checkups are happening, and era of general checkups where patients come with a lot of reports, where testosterone is part of most of these reports. So how do we interpret this testosterone? I mean, is therapy necessary when you have testosterone, and is the patient going through andropause? Now, it is defined as a biochemical syndrome where with advancing age, the patient starts developing lowering of serum androgen levels. Now, how does this affect the quality of life? Is there any quality of life? I mean, do we really need to replace testosterone in these patients? Now, andropause, we don't want to use this terminology because it's an outdated terminology. What we want to use is one of these terminologies, such as ADAM is very well accepted terminology. It is an androgen deficiency of aging male or late onset hypogonadism. These are two accepted terminologies when we look at andropause. Now, why it occurs? We know that, as I explained in the earlier part of my lecture, similar to men, andropause, the necessity of testosterone reduces as the patient ages. But I'll explain through the future slides that testosterone is needed for very many functions of the body. Where So testosterone reduces, then what happens is all your muscle health, bone health, etc. starts coming down. So these are the effects of testosterone we've been reading through our medical studies days. One of the most important effect we know is the fertility. But as the patient's age, fertility is no more a concern. So what testosterone does is, it has a most important effect according to me is your bone. Bone health is very strong because of testosterone in men and estrogen in women. Muscle power is there, and then it has some effect on the central nervous system also. Generally you'll feel better, your libido is better, aggression is there, your whole psyche is made by testosterone. So we understand that testosterone, even though not necessary for fertility, it is definitely needed. These are some of the effects which I explained, the CNS effects, the liver effects, the blood effects, where hemoglobin in men is more than women. Bone is most important effect. I see a lot of patients who come with fractures in young age, they may be having testosterone deficiency. So we should keep thinking about this entity. So why does it reduce? As I told earlier, as in testis is an organ like any other organ. The functioning starts reducing as the person ages. So decreased rate of production of testosterone by testes, decrease in size. Now we should understand that any patient, any critical illness they go through, any, for example, infections, pneumonia, any cancers they go through, testosterone levels can be low in these patients. Now with increase in longevity, we are seeing a lot of chronic illnesses such as diabetes, chronic renal failure or COPD. In these patients, what happens is your testosterone comes down. The most important topic which is dear to my heart is, along with antimicrobial resistance, we are seeing a nuisance, public nuisance of corticosteroid abuse. I see every day, I see 2 or 3 patients who come with abuse of corticosteroids. Now there's a study which was done in North India which found that about 80% of patients were on unwarranted steroids, and they were on about 30% were on steroids for more than 1 year. So definitely we should suspect corticosteroid abuse in India, especially when ease of availability of over the dose prescriptions, corticosteroids is rampantly used. So this can also reduce your testosterone. Now with the availability of food, obesity is a common factor where your testosterone can be low. So how does the patient present to you? They can have low libido, they can have insulin resistance which can present with diabetes, erectile dysfunction, this can be there. And some of the patients can present with osteoporosis. How do they present? They can present with fractures. So a male patient presenting with fractures, our antenna should be up. We should always suspect any secondary cause. So these are some of the features how the patients present. Energy can be low, sense of well-being can be low, fatigue, decreased libido, erectile dysfunction, then your lean body mass, height, body fat. So any of these patients who can present with, you should suspect testosterone deficiency. And they can also have some of the CNS effects such as irritable mood, tiredness, lethargy, depression, low self-esteem. So how do you diagnose testosterone deficiency? This is very important. How do we diagnose? As I said, with a lot of general checkups, you have a testosterone value. So we don't look at one value when we diagnose testosterone. So we should understand that nowadays the methods of measurement are improving. Initially we used to use radioimmunoassay. Now one of the best method is CLIA, the chemiluminescent immunoassay. But better than that is your LCMS steroid profile. So that is where your testosterone method starts. But we should understand that this has got a circadian rhythm. If the general checkup blood is taken in the afternoon, the testosterone level will be low. So the testosterone has to be drawn between 7 to 10 a.m. because of the circadian rhythm. You should always look at the lab. But don't go by one report when you diagnose androsterone deficiency. And these are some of the numbers. More than 300 we are comfortable. More than 200 also we are okay. We don't need to diagnose or we don't need to evaluate. It is an important slide. Looks a little busy, but it's a very simple slide. So whenever somebody comes with a clinical history, which I suggested, you look at testosterone, which is done properly, which is at 8 a.m. So once your testosterone is low, then we try to diagnose if it is because of pituitary or your testes.
So what we have to do is we have to do LH and FSH. Yeah. If LH and FSH is high, then it is testicular failure. If LH and FSH is low, then they can have a pituitary problem. So I've picked up a lot of patients who have come with low testosterone having pituitary tumor. So that should be kept in mind because that changes your whole management. So how do we treat testosterone deficiency? Now we should, as I said, see, testosterone can show the patient's health on the whole, how the patient is doing. See, simple things like obesity can change the binding globulin and testosterone can be low. So these things will definitely help in reduction or improving of testosterone, such as weight loss. So all the patients do a BMI, check for weight. Now this is the most important slide. Where does testosterone therapy, where is it actually useful? So we should be very clear, because now with availability of anabolic steroids and steroids, a lot of patients demand for testosterone therapy. So we should be very clear that it has been proven to be of beneficial effect in these conditions: bone health, mood, obesity, metabolic syndrome, sexual function. These are the only 4 domains where your testosterone can be helpful. Now with increase in longevity and cancers, we should always keep in mind hormone sensitive cancers such as breast or in women, or prostate cancer. It is an absolute contraindication. Some patients can have CVT, that are planning fertility. Your physical function, cognitive function, the evidence is very unclear. So this is where I'll put the treatment of testosterone. Now how do we replace testosterone? Oral therapy we don't use that much. Oral testosterone, please don't use it. They've got a lot of effects on the liver. They can cause hepatitis. The effect is not much, so oral therapy is not recommended. So we don't use oral therapy. Buccal delivery system is available in some countries. It's not available that much in India. Again, this is out of vogue. This is the most important therapy which is available for us. It is easily available. We can use it either thrice weekly, once depending on the patient's levels, or twice weekly, or there is a 3-monthly preparation which we give once in 3 months. So easily available, inexpensive, but choose your patient well, because this therapy has got its own side effects. Testosterone gel is available, but there are some problems with the gel, transfer of testosterone to the female counterpart, etc. In India, where humidity is high, the gel may be washed out. So there are a lot of side effects with testosterone therapy. That is why we don't give testosterone therapy to all the patients. Same like we don't give oral contraceptive pills to postmenopausal women, because the largest trial showed that there was a lot of problems with the pill, so that study went off. So same problems with testosterone therapy. It can worsen your sleep apnea, prostate problem, prostate cancer, increased thrombosis and stroke, and DVT, so that is venous thrombosis. So this is my last slide, so I'll summarize again. So what we have learnt is andropause, unlike menopause, is a very slow and gradual process. Okay, it needs to be suspected in men who are aging. Especially I would keep a pointer, which is your osteoporosis. If anybody comes with male osteoporosis or fracture, we should remember that testosterone deficiency can be there. And there are specific domains where we treat. And second thing is, you should do the testosterone level properly, that is 7 to 8 a.m. and then try to diagnose. Don't just go by one report. There's a concept of free testosterone. There are the problems with free testosterone with assay, etc. So we don't depend on free testosterone. We look at serum total testosterone. And once you have made a diagnosis, once you have made sure that there are no other contraindications, you tell the patient to lose weight, because your general health improves your testosterone levels. Then once they lose lose weight and their health is good, still your testosterone is low, then in specific subset of patients, you can consider testosterone therapy under expert guidance. Thank you.
Thank you, sir. I request Dr. Lata Mehta to felicitate our speaker. Yes, madam, please introduce our next speaker.
Modern day CABG. Today's topic is modern day CABG, what every clinician should know. Dr. Nitin Gundre. He is a senior consultant cardiac surgeon with cardiac surgeon with 15 years experience, trained at King Edward Memorial Hospital and Lokmanya Tilak Municipal General Hospital. Has performed 6,500 high-risk beating heart bypass surgeries with strong outcomes in complex cardiovascular cases. Specialist in total arterial off-pump CABG, minimal invasive cardiac surgery, mitral valve repair and replacement, aortic aneurysm dissection surgeries, TAVI tower, VSR repair, ASD, VSD repair, intracardiac clot and infective endocardial surgery. Hospital attached in Lilavati Hospital, Somaya Hospital, Research Center, Glendale Global Hospital, Wockhardt Hospital, SL Raheja Fortis Hospital, Zen Multi-Speciality Hospital, Godrej Memorial Hospital, and Beaton Hospital. He is recognized as the best cardiac surgery in Mumbai. By Outcome magazine is listed as top doctor in Mumbai. By India Today for 5 consecutive years since 2020. Advanced trained in robotic cardiac surgery, minimally invasive wall repair, Tower certified program, and National Organ Retrieval Workshop, and heart transplant workshops across leading cardiac intensive in India. We welcome Dr. Nitin Gundre.
Very good morning. Greetings from Lilavati Hospital. My name is Dr. Nitin Gundre. I'm a consultant cardiac surgeon and minimally invasive surgeon, presently working in Lilavati. And I thank you, Borivali Medical Brotherhood Association, for the invitation, and really congratulate you for the very well organized conference. Really nice concept. So today we'll be discussing about modern day CABG. So why we chose this topic was this is the commonest cardiac surgical procedure performed, and every now and then our friends, families will come with angiogram reports and they will seek our opinion. So I thought I will cover everything about CABG, and pertaining to our theme, I will talk about what is recent in the CABG, including robotic CABG. So in general, we'll be discussing in this flow CABG overview, indications, recovery risk, then what is off-pump CABG, what is on-pump CABG, what is total arterial CABG, minimally invasive CABG, hybrid and robotic CABGs. So there are certain doubts around this procedure. A lot of people are scared, they have some myths. So we'll be addressing one by one initially, because people will come with angiogram report and they'll ask, is it very risky? Shall I go for angioplasty? Can it be avoided? Will it be very painful? And will I be able to lead a normal life after CABG? Can I travel, drive? And can I work after this surgery? And is it very expensive? These are the common questions which will come to our patient's mind, and we'll be addressing all of this. By the end of the discussion, we'll have clear answer about each one of this. So coming to the CABG basic, what is it? So CABG is a surgical procedure primarily done to relieve angina, to reduce risk of heart attacks and sudden cardiac deaths. And basically what we do is a artery or a vein from elsewhere in the body is taken out and used to bypass a blocked portion of the... Do you have a pointer? blocked portion of the coronary artery. So thereby it improves the blood circulation to the heart. Okay. So this is like on your left you can see there is a blocked segment, and on your right the internal mammary artery is used to bypass the blocked segment, and then circulation to the heart is restored. So anyways, so what are the indications? In what cases CABG is established and is superior, found in multiple trials, and what are the guidelines? So any multivessel disease, to simplify it in layman language, if block is less than 50%, risk of heart attack is very less, those can be safely managed with medicines. Anything more than 70 is critical. And sorry, pointer. Okay. So anything less than 50 can be safely managed with medicine. More than 70 is critical, and risk of heart-related events is very high to the extent of more than 90%. So a procedure which normalizes blood flow to the heart is required. So there are two ways of normalizing the blood flow to the heart. One is angioplasty, second is bypass. So in general, if there are one or two blockages not in the left main, not at very critical location, non-diabetic, non-smoker, non-CKD patient, angioplasty can give us a fair long-term satisfactory result. But if you talk of data, the only proven benefit of angioplasty is primary angioplasty in situations of acute heart attack. So there have been trials which show that elective angioplasty and medical management no survival benefit. So coming to the indication, but this is whatever we will be talking is not that this procedure is superior or inferior. We are talking about triple vessel disease diabetic patients who are scared of undergoing CABG despite guidelines and despite huge benefits. So we'll be talking in that context. I'm not here to show any superiority or inferiority of angioplasty or bypass. So indications, what medical science tells is any multi-vessel disease, triple vessel disease, all three systems, one right-sided, two left-sided, is a class 1 indication. Significant left main disease, diabetic patient, severe LV dysfunction patient, there is a clear benefit of bypass over angioplasty. Diffuse disease not amenable to PCI, lesions with anatomy not suitable for PCI, like if lesion is 100%, then you are not sure whether it will be crossed, and then you end up plasting the vessels which are 70-80% and leaving 100% vessels. So that will be an incomplete revascularization. And history of recurrent stent failure. So previously patient has undergone angioplasty, he is diabetic, and is likely to come back again with stent failures, because diabetes, smoking, and CKD is a very high risk factor for stent failures. So continuing with the indications, failed previous angioplasties or stent restenosis, complications of PCI, fracture, stents, coronary ruptures, and if there are mechanical complications of ventricular MI, like ventricular rupture or severe mitral regurgitation. In that case, you need to address both the pathologies, not only ischemia part. So what are the benefits of CABG? It restores blood flow to the heart, relieves chest pain and ischemia, improves patient's quality of life, enables patient to lead a normal life, lowers risk of repeat heart attack, lowers risk of sudden cardiac death, and most important is protection from future disease, because coronary disease is a progressive disease. So what we are doing is tackling the short-term problem. If there is a block which is more than 70%, if we handle it, disease process continues, diabetes affects all the microvasculature, and in future if proximal lesions develop, and whatever treatment we are offering, is that giving benefit or protection from that disease, that also we need to take into account while deciding whether to go for angioplasty or bypass. Because we'll be seeing in subsequent slides, the biggest advantage of bypass or angioplasty is one, the vessels are own, so body doesn't react to it, it's not a foreign surface. Second, it grows with time and demand. If we graft a vessel with a 70-80% block, in future it becomes 100%. It grows in time. So now it is 2 mm, in future it becomes 4 mm, 6 mm. So stent being inline structure, it cannot grow. And third is protection from future disease. So now if there is a lesion which is 90%, that is stented, and before that lesion there is a plaque, 30-40%, 10-20%. In future, if that plaque progresses, stent, even if it is patent, it is not useful, because blood flow is still dependent on a disease circuit. But if you bypass that block 90% with a new vessel, so whatever new blockages develop before that earlier lesion or grafted segment, everything is taken care, because blood flow to the heart is not dependent on the disease circuit now. It's a new circuit. So even if existing block progresses or new blocks develop before the grafted segment, future circulation to the heart is not affected. So that is the beauty of the bypass procedure. So it is called protection from future diseases. There are a lot of papers comparing angioplasty versus bypass in triple vessel diabetic patients, and all of them have shown superiority of CABG, 40% higher mortality in PCI groups compared to bypass groups at the end of 10 years in syntax trial, those who were indicated bypass procedure but underwent angioplasties. Okay. So ACC-AHA guidelines, multivessel diabetic patients, all these trials showed that stent failure rates are higher in diabetics, smokers and CKD patients. Mortality is higher. There is something called MACE, major adverse cardiovascular events. So all the MACE rate is higher in stented group. Once angioplasty is done in a diabetic patient, triple vessel patient or smoker, he of chance of having he coming back with another episode of acute ischemia, or he requiring repeat angioplasty or ultimately bypass is very, very high because of diabetes and native disease process. But once done, by and large, bypass is a relatively longer lasting solution. So in available scenario, best available longest lasting solution for diabetics, for smokers, for CKDs, for multivessel disease, for left main disease is CABG. So merits of CABG is superior to PTC in diabetics, no limitation of anatomical subset like calcium, 100% block, in which you may require rotas, and that increases the risk of the procedure. But in bypass, we are not at all handling the disease segment, may it be 90% or 100%. We are grafting distally. So anatomical subset limitation is not there. It is most preferred procedure for multivessel and left main disease. No limitation of calcium, thrombus or total occlusions, and relieves symptoms effectively and better in diabetics and CKD patients. So comparison is longevity. So stent, as I mentioned, being a foreign surface, any surface put in the body, if it is foreign, body tries to reject or react to it. So stent being a foreign surface, body generates some reaction. There are two main reasons of stent failure. One is stent thrombosis and stent restenosis. So stent thrombosis is clot getting formed inside the stent. So that can happen immediately after deployment to few days, few weeks, few months. So it is irrespective of the procedural expertise or stent quality, because as long as blood circulates in the body, it doesn't clot. The moment it comes out of the body and falls on a surface or taken into any tube or something, unless chemical is added to it, it will immediately clot, because blood has a tendency to form clot when it comes in contact with foreign surface. So stent is a foreign surface for the blood. When it comes in contact with the stent, it has a tendency to form clot. To prevent that, we give antiplatelets, but still it is not as non-thrombogenic as blood vessels, which are used in bypass, because blood vessels naturally are meant to carry blood. So there is no question of blood getting clogged when it comes in contact with bypass blood. So that is a main difference. Stent is a foreign surface. When blood comes in contact with the stent, it has a risk of forming thrombus, and this risk is anywhere between 2 to 5%. So that is called stent thrombosis. So that is not applicable in bypass procedure. The another main reason of stent failures is stent restenosis. So as we already saw, there is a stent segment. We'll see in the. So this is a blocked segment. So in angioplasty, what is done is wire is placed, balloon, and stent is placed here. So basically what is happening is that block is getting crushed between the stent and vessel wall. It is not being taken out. So this stent being a foreign surface, the block being between the wall and the stent, and because of constant friction, stent is a relatively stiffer structure made of metal and plastic. Blood vessels are natural biological soft structures. So because of the forces acting there, this block is likely to grow inside the stent again. That is called restenosis, and that is common in diabetic smokers, kidney patients, and all diffusely diseased patients, hypercholesterolemia, family history. So if this block recurs in the stent, that is called stent restenosis, and that again requires revascularization. But in bypass, what we do is, this is PD. So we will be grafting here. This is LAD, we will be grafting here. So if stent is placed here, stent is placed here, this plaque in the future, if it progresses, even if stent is patent, the circulation to the target area is affected. But in bypass, when we connect the blood vessel here, even if multiple blockages develop proximally, the circulation to the heart is not affected. And there is a tendency of blockage formation in the first half of the vessels, because those are more exposed to the pressure variations. Okay. So the stent thrombosis and stent restenosis, both the things are not applicable in the bypass. So because of that, the longevity of bypass is much higher. So as we discussed, it deals with the disease segment, stent. Future disease proximal to the stent adversely affect the blood flow. As number of stents increase, cost increases. If patient presents with 6 blockages, then they will require probably 5 or 6 stents, and the cost proportionately increases. But even if you put 7 grafts, 6 grafts, 5 grafts, the cost doesn't change, because blood vessels are patient's own. So multi-vessel disease cost doesn't change. And chances of incomplete revascularization are more. If you are looking at 5-7 blocks, 2 of them are calcified 100%, then we may end up opening 3 and leaving another with medical managements. So coming to the types of this was a broad comparison between angioplasty and bypass. Even if patients are scared, as a clinician, it's our duty to tell them that this is superior, this is time tested, and we'll be coming in subsequent slide. We will be seeing about the risk. So and the recovery and resumption of the normal lifestyle. So all those concerns, if you can address well, then patients will choose the best treatment for them. So conventional or on-pump CABG, off-pump CABG, minimally invasive CABG, hybrid CABG, and robotic CABG. So this is a trend. This oldest is being on-pump CABG, Lima vein, then came off-pump CABG. In off-pump CABG, then came from Lima vein to total arterial, then came minimally invasive, then hybrid. And we are doing something called on-table extubation. So this is like upper in the chain. So patients nowadays, almost 75% of our patients do not require ventilator also. We'll be seeing in the subsequent slides. And we are happy to tell that we are the only team in Mumbai whose 75% patients do not require ventilator also. So we'll see what are the advantages of each of them. So risk, in general, if you talk about a patient who presents with normal LV function, risk is less than 1%, which is quite less comparable to stenting. Much less compared to the risk in not treating the disease or treating only with medical management. Untreated disease, patient will continue to have symptoms, his quality of life will be compromised. There will be constant risk of MI, and there is a constant risk of sudden cardiac death. So sometimes what happens, there are patients, if there are 100 patients who have triple vessel disease in whom bypass is indicated. So guideline wise, if you offer CABG, end of 1 year, end of 5 years, almost 98 will be alive. But if you put them on medical management, 85 will be alive, 15 will not be. But those 85 at the end of 1 year for whom CABG was advised, some alternative paths or some people take advantage that you were advised CABG 1 year back and you are still alive at the end of 1 year with medicines. So 85% will still be alive. But those 15% who succumb to the MI is not taken into account. And then sometimes they present late with, originally they had normal ejection fraction, triple vessel disease, put on medical management. 1 year later they present with 25% ejection fraction, some mitral regurgitation. They are much higher subset that time with lesser benefit. So timely treatment is also important. So risk mainly depends on whether they are presented after MI or before MI, ejection fraction, how much is the ejection fraction, whether there is associated regurgitation, associated other comorbidities like kidney, brain or renal. So normally a normal bypass close is pretty fast and smooth. 1 day prior patient is admitted. They undergo surgery under general anesthesia, no pain, no memory. Our patients are extubated on table. They come in the ICU conscious, talking to the relatives. Within few hours they are started on meals. They start walking early. Normal average ICU stay is 2, maximum 3 days and 2 days ward. So if patient's willpower is good, compliance to the diet exercise is good, patients are going home as early as 5th day. Average stay is 6 days plus minus 1 day. So and we take care of pain very well. That's why we are able to extubate patients on table. We do multimodal pain management. In OT we give blocks. I'll be talking in subsequent slides. So short-term recovery is post-op day 1 or same day in the evening they start having diets and physiotherapy. This start sitting by the side of the bed within few hours. And after discharge, They need not do dressings. They can have bath daily. They can move around, walk, travel with accompanying person. And 2 weeks from the discharge, most of our patients, 98% of our patients can resume their work. They can travel, they can self-drive. Few of the patients come from abroad, their relatives, their insurances are here. They get operated and they fly back and resume their work with teleconsultations. So if you are going for a conventional CBG, 3 months chest belt is the only thing, and avoiding excess weight during initial few weeks. These are the only restrictions that too related to sternal healing and not related to CABG per se. And there are zero restrictions after 3 months. So patients can trek, gym, drive, anything. That is not there is not a single thing which CBG patients cannot do. So a person of their equivalent age, whatever he or she can do, everything CBG patients can do. So long-term CBG is very simple, little bit modification in diet, regular brisk walking, no major fancy exercises, and basic medicines, as you know, antiplatelet, antihypertensive, statins, and regular follow-up. So we follow up a stable patient once in 6 months. They normally follow up with their primary physicians or primary consultant. So little bit of a diet, most of the diet pyramid, most major portion should be vegetable, fruits, lesser carbohydrates, lesser salt and fat. We'll be talking in short about which oil and what, because they will be coming up to you asking what is good oil, what is preferred quantity, how to avoid salt. So medication, as I mentioned, basic medications, only those who have very low ejection fraction need ARNIs or AC inhibitors. Otherwise, a combination of statin and antiplatelet, that Ecosprin Gold or Reservoir Gold, and one beta blocker. These are the only 2 medicines after dinner, that's it. A normal ejection fraction patient, triple vessel, who has underwent CABG. So again, coming back to the first slide, have we addressed the myths? Is it very risky? As I mentioned, 1% risk in today's era. And we'll be seeing in the subsequent slide, our results are share better than world standard because we do beating heart, we do total arterial, and we manage patients very well. So in general, we have operated more than 7,000 patients now. Stroke risk worldwide is 1%. Our 7,000 patients, only 2 had stroke. One is subclinical stroke detected in some other finding, and one had minor stroke. So that is the difference, because most of the literature comes from West, and 90% of the bypass is done in the US and UK are on pump. The expertise in CABG is most advanced in India. So we are having currently, our conference is going on, joint conference between American Association, European Association, Indian Association, Joe Convention. I had a lot of talks there. So we had a lot of debates. I'll be seeing in, quoting in few other slides. So off-pump CABG, India is the pioneer in the world. So one by one, have you addressed? So risk is less than 1%. Can it be avoided? Yes. If only if it is a primary situation, angioplasty is superior. Rest all things, even if it is indicated, it should not be avoided. Is it very painful? No. Pain is managed very well. That's why we are able to extubate patients on table. Will I be able to lead a normal life? Yes, of course. Within 2 weeks, you can resume your work. Can I travel dry? Yes, after 2 weeks. Can I work? Yes, of course. And CABG is expensive, as we saw. Multi-vessel disease, multiple stents, taking into account risk of repeat hospitalization, repeat events, and ultimate repeat angioplasties or bypass. All this taken into account, bypass is not at all expensive. So some basic things about on-pump, off-pump. So the most primitive form is on-pump. Heart is arrested, the entire circulation is being taken care by heart-lung machine. So there are a lot of disadvantages of blood traveling through a foreign circuit. So our natural blood flow is 120/80 pulsatile. So machine blood flow is non-pulsatile, it's a uniform, 60 map, 70 map. So there is a different physiological difference. So normal blood pressure is pulsatile and pump blood flow is non-pulsatile. So it leads to different reactions being generated, complement reaction, systemic inflammatory reaction, kallikrein reactions. So all these leads to ill effects on all the organs. So obviously stroke rate is high in on-pump, kidney injuries are higher, bleeding risk is higher, lung injury is higher. So there are books of effects of CPB on each organ. Book on effects of CPB on kidney, effect of CPB on brain. So obviously if you can match the same quality of anastomosis and same number of bypasses in an off-pump manner without taking the help of CPB, it is any time superior. So but what is happening is some centers in where they are conventionally doing on-pump CABGs, and then when they try and compare it with those who are not doing it since years, off-pump CABG, then they struggle, they end up compromising the quality of the anastomosis or number of grafts, and then they say both are same. But if you logically think, if you can do the same job, same number of anastomosis, same quality of anastomosis without the help, without non-pulsatile flow, without all these complement reactions, CABG is anytime superior if it done on off-pump. On-pump has lot of ill effects. So off-pump is surgery is done in a beating heart manner, pulsatile flow to all the organs, all the ill effects of foreign circuit are avoided, bleeding is less, infection is less, systemic inflammatory reaction is less, and organ preservation is better. So this is just to give you an idea about how the Lima vein, which is the basic most surgery looks. All the grafts are put on aorta. You can, if you can see, if you can make out. So because of that, there is a handling of the aorta, and which that leads to higher risk of strokes. So in off pump also, if you go for Lima vein option, there will be a higher risk of stroke because you are handling aorta, and coronary and carotid disease go hand in hand. Most of the patients will have some plaques in the aorta, some plaques in the carotid. If you can do unaortic surgery, that is superior from stroke point of view. So disadvantages of on pump we have already seen: increased fluid shifts, all those inflammatory system activation, myocardial protection problem, and myocardial edema, leading longer recovery times. Disadvantages of on pump, same, blood transfusion reaction is more, non-pulsatile flow, and all these organs are at stake: lung, kidney, brain. So advantages of off pump: reduced risk of renal injuries, reduced bleeding, blood transfusions, less systemic inflammatory response, less stroke problems, less atrial fibrillation, and safer for kidney patients. Advantages continued: less wound complication, lesser hospital stay. All this is proven by evidence and data. Reduced inotropic requirement, reduced cost because you are not requiring any machine supports, faster recovery, and reduced ventilation times. So this is about off pump, on pump. Now coming to Lima vein versus total arterial, unaortic surgery. So just to give you an idea, in previous slide we saw all the grafts were put on aorta. In this, if you can make out, this is Lima Rima Y. So aorta is not handled or touched. This is aorta. So since you are not handling aorta, you are taking out the risk of strokes. So you can do multiple grafts, 5, 6, 7, whatever numbers are required, and you're not inserting tubes into the aorta or RA to take the help of CPB. So off pump total arterial in today's era is the best thing for revascularization. So there are a lot of trials. I'll be talking in detail about radial and Lima. So in total arterial also we have options. 2 internal mammaries and 1 radial artery are the major sources of arterial revascularization in Y manner, unaortic. So if you do Lima radial Y, there are some disadvantages and advantages. If you do total arterial Lima Rima Y, there are some disadvantages. So conventionally, Lima Rima is the only thing which is taken as a total arterial. But now there are a lot of papers, randomized trial data, which suggest that Lima radial Y is superior. Lima Rima Y, if you take out both the internal mammaries, then blood flow to the sternum comes from these 2 circulations. If you take Lima, that is fine, that is class 1 indication. If you take Rima, there is risk of non-healing and increased risk of infections. And that is high in elderlies, those who have osteoporotic bones, diabetics. So that risk is not worth taking. So if you want to pass on all the benefits of total arterial grafting and avoid the downsides of the total arterial Lima Rima surgery, then Lima radial is best option, and it is backed by a lot of evidence. We'll be talking, this is a RAPCO trial, randomized control trial, 15 years data. Lima vein, obviously Lima is superior, there is no doubt. Lima radial and Lima Rima, there are 2-3 differences. We'll talk about the guidelines. So European guideline and American Association guidelines all speak of Lima as a first indication, but not Rima. Radial artery is class 1 indication, and bilateral is a class 2 indication. So it is not recommended. Disadvantages with BMA. If you take out both the internal mammaries, there is increased risk of deep sternal wound infection. That leads to quality compromise. You may be seeing few patients discharging sinuses, dressings being done, repeat procedure, wire removal, VAC dressings. All this is common if both the internal mammaries are used, because you are compromising the blood flow to the sternum and healing is affected. So bleeding is more because you are entering 2 pleural cavities, need of the sternal reconstruction, prolonged ventilatory support. So one of the reason of prolonged ventilation or nobody is able to extubate patients on their on table is because you are ending up entering two pleural cavities. So that definitely adds to the pain, lung recovery, and ventilation capacities. So total arterial RAPCO trial proved that radial artery is superior to REMA as the second best conduit after LEMA, maintains all the advantages of total arterial and takes care of all the downsides or concerns of the BEMA and lesser MACE rate. This is also significant. It is not only about the sternal healing, major adverse cardiovascular side effects are less if you use LEMA radial combination versus LEMA REMA combination. So this is how LEMA radial Y looks. Similar, there is no difference. Only thing is you are sparing right internal mammary for sternal healing and you are using alternative radial conduit. So multiple grafts. In fact, radial has a lot of advantages. We'll see in subsequent slide. So this was my presentation in ongoing our European, American and Indian Cardiac Association joint conference, and we had a debate. And one Canadian surgeon spoke on REMA and I spoke on radial, and it was so heavily appreciated. Radial is a clear superiority. So what are the scientific evidences? Guidelines saying radial artery class 1, REMA class 2A. Sternal safety excellent, potential risk technically easy, versatile. Versatile means it is a bigger conduit. It can accommodate as many number of grafts as possible. Radial REMA has a limited length. So when you put it to the last artery, it may get stretched, or last portion is smaller in caliber, so patency rates are inferior. Reproducibility is good and broader applicability in minimally invasive also. So coming from on-pump, off-pump to vein, total arterial to minimally invasive CBG. So minimally invasive, there are two major approaches, minimally invasive thoracotomy and robotic. So robotic, at present, there are no robotic stabilizers. So totally endoscopic robotic CBG is not possible. So they are planning to come up with the stabilizers. But for now, only LEMA harvesting is done robotically. Rest, all the things are done similarly, minimally invasive. So minimally invasive, you don't open the chest through the center. So there is no bone cutting involved. So it has a lot of advantages. So this is how minimally invasive CBG looks during the surgery. Oh, sorry. So minimally invasive total arterial grafting. So you are going between the ribs, not cutting the chest bone. So LEMA, and this is LEMA radial Y, and there are 4 or 5 grafts. So this space being constrained, there is a visualization problem, but you can do 4 or 5 grafts with total arterial minimally invasive surgery. So this is the amount of scar patient gets. This is the healed scar. And advantages of minimally is more cosmetic, less pain, less blood loss compared to standard conventional, less tissue trauma, reduced ICU hospital stay, faster recovery, early resumption to the work and activity, and in reduced situation, it has some advantage. So drawbacks, some learning curve, we have already taken care of that, specialized instrument, cost, and it is not applicable to all this thing. So, sorry for that. So now next thing which is upcoming is robotic CABG. So in robotic CABG, currently if you talk of CABG, only LEMA harvesting is possible, and it is not applicable to totally endoscopic CABG because there are no endostabilizers available. And in future, we will be having endostabilizers. It will take some time to come to India. It is not there in US right now. Sorry for that. Oh, it's, I think, okay. Sorry for that, 2 minutes. We are coming to the conclusions. So this is how, I think I'm going. ये थोड़ा सा ठीक है, no worries. So there is something called hybrid CABG. वो बंद कर दो, हाँ. So hybrid CABG is you do minimally invasive for the left-sided targets, and for right side you do angioplasty. So this concept is being studied, not yet proven, but there are certain advantages if patient presents with right-sided MI, and then right side is already stented, then you left side you do only MICAS, minimally invasive CABG. So this is between robotic and MICS. So hybrid CABG. And last thing which is coming up is robotic CABG. In robotic CABG, as I mentioned, it is in evolution. Only indication right now we can do with robo is mammary harvesting, and then rest of the procedures is done minimally invasive manners. So I'll just show you how it looks. Okay. So this is minimally invasive, less scar, less pain, faster recovery, lot of advantages. And hybrid CBG we already spoke. This is how the robotic CBG will be. Surgeon will be sitting at the console, and right now it is quite bulky. Some Indian players are entering into the robots, and in future we will see advances. So there is something called fast tracking in cardiac surgery, ERAS protocol, enhanced recovery after surgery. So as I mentioned, we do on-table extubation. It affects pain and early mobility. So on-table extubation, there are a lot of advantages. Ventilator is not required in the post-op period. So patient recovers faster. There is early mobilization, improved hemodynamic stability, enhanced patient comfort. So whatever downsides of the ventilated tube, those are taken care. There is no tube discomfort. There is no tube psychosis. Patient's respiratory complications are lesser, like ventilatory associated pneumonias. There is no risk of VAP if patient comes extubated. And we can start him on orals early, we can mobilize him early. So overall there is a risk reduction. So the biggest concern after shifting to the ICU is coming out of the ventilator. If patient is coming like any other minor surgery without ventilator, that risk is already taken care. So this is how we do on-table extubation. We do 2D echo-guided blocks pre-surgery. So patient remains hemodynamically stable, and post-op he is comfortable breathing. So take-home message is CABG is safe, it improves quality of life, hard time approach is ideal, meticulous patient selection is important. Goal is to have complete revascularization and quality of anastomosis and safety of the patient. For the sake of doing, you should not be pushed to minimally invasive or any other alternative. It has to be safe for the patient. So patient safety is priority over cosmesis and speed of recovery. So few slides on prevention, since we are talking about holistic coronary. Better than cure, medical profession itself is a risk factor for coronary artery disease, not mentioned in the books because our lifestyle, diet, sleep pattern, stress, average life expectancy is less. So what we can do is we can have simple healthy dietary modifications. For heart, best is olive oil, next best is rice bran oil. ½ liter per person per month should be the restriction we should recommend to our patients. No addictions, no tobacco. Maintain a healthy weight. So your average height minus 100 is more or less ideal body weight. If I am 179 centimeter, my ideal body weight should be 79 plus minus 1. And sleep of 7 to 8 hours is critical. So regular exercise, at least 45 minutes a day, and at least 3 to 5 days a week. Stress management is important, like what you, that's why I told this concept is very nice. So you need to take breaks, you need to pursue your hobbies. And the stress busters are important, work, family balance is important, and financial freedom is important. So all these are interconnected. They affect your health, they affect your stress, and that ultimately leads to increased risk of coronary artery disease. So what we are looking at in the future is we are towards becoming a minimally invasive and valve repair center, pioneer at Lilavati. We are getting robo in future, and we'll be starting robotic cardiac surgery program, more applicable in ASDs and mitrals. Currently, CABG is less relevant, and we are looking at Center of Excellence for Cardiac Surgery in the future. Thank you so much.
Thank you, sir.
So
I
I'll be
request
happy if there are any questions, if you want to ask anything related to CABG or cardiac surgery.
Thank you, sir. I request Dr. Lata Mehta to felicitate our speaker. Time for next lucky draw.
Okay, the next lucky draw is by Chamunda Investments. Pragati, bahane bolo na. Hope all of you have visited the stall from Chamunda Investment. You have dropped your card. Okay, fine. So I'll request Akshay to please come forward. Akshay, come here. परेश सर किधर है, आप आइए. How many have to remove? Three. Okay, we'll remove the three names. They contact Akshay. They will take your address and they will drop your gift at your clinic. Simple, smart बंदा है, investment वाला है ना. Okay, a request sir, एक आपने गाली पड़ेगा. एक तिलक डाला है तूने, गलत बात है यहाँ. And the first one is Dr. Seema Verma. Okay, एक. हाँ हाँ. एक. मैम फोटो, हाँ फोटो. And the next ये मोबाइल किसका घूम गया था? हाँ, डॉक्टर गोपाल आचार्य. आ जाइए सर. ओके, ठीक, साथे ले सर. सर तुमने साथे बोलने ले लिए છે. Okay, and the third one is Pragati. Ma'am, wait a minute. We'll have one click तो proof रहेगा ना, ये किसको जाके दे रहा है. And the third one is Dr. Salia. Sylvia. She's there? Yes, ma'am. Please come forward. And done? Bakka? Okay, we'll have one quick photo with them. Till that time, I request Dr. Tejal to please introduce our next speaker and our dear Dr. Manoj Rajani, sir. New Wins Hospital.
So our next speaker is Dr. Manoj Rajani, sir. He's a senior consultant neurologist, having done his DM neurology in 2000 and practicing in western suburbs for last 25 years. He has started the first dedicated neuroscience hospital in western suburbs, New Wins, specialize in catering to patients with problems like paralysis, stroke, coma, brain tumors, epilepsy, vertigo, neuromuscular disorders, etc. His centers has facilities like neuro ICU, stroke unit, advanced laminar airflow, neurosurgical OT equipped with Carl Zeiss, that is German, microscope, C-arm, etc. to perform complex neurosurgeries, physiotherapy, speech therapy, and occupational therapy. Rajani sir has actively participated in many national and international conferences. He is also the past president of Malad Medical Association and our platinum sponsor, New Wins Hospital. A big round of applause for Mr. Manoj Rajani sir. Welcome, sir.
Am I audible? Yes, yes. So I hope everybody is enjoying. We had a very pleasant conference, I believe, and there's been a lot of fun activities along with the academics which are going on. So yesterday we had in the evening sort of a meditative session with music and all those things, which I think has rejuvenated all of you. All the mental faculties have become regenerated, and hope your powers of concentration have also increased. So I am hopeful that you will find this talk informative, and it will be, I think, helpful in your day-to-day practice also. See, this is a talk which I have some sort of modified form of this I have presented earlier also. But because this topic is so important, I will be dwelling on why it is so important. That is why I keep on speaking about stroke in these conferences, because actually you people are playing a very, very big role in management of stroke. So I will be coming to all those aspects as I go ahead. So first of all, let me start off with the definition of stroke. What is stroke? You know, what is stroke? Stroke is basically any neurological deficit which is arising out of some vascular problem of the brain. It's a very common entity, and as you know, most of the people think that the stroke is synonymous with hemiplegia, but it's not like that. I will be dwelling on this topic later on also. So you have to understand that any neurodeficit which is happening because of stroke is stroke. So it's not only hemiplegia, there can be many other manifestations also. So you have to be aware about this to pick it up early. Why I keep on repeating this topic again and again is because of the importance, the public importance, the health importance. Is the third largest killer in the world. So it's a very common disease. It's not something theoretical or something. And you have a very important role in picking it up early, because many of the therapies which are coming up have a very brief time frame, very short window period. So if the patient is not diagnosed, picked up by you people on time and sent to a stroke neurologist on time, that stroke window period will go away and the patient may be left for paralyzed or may die for whole. So this is going to be a very bad situation for the patient. There are a lot of treatments which are coming up which can improve the stroke outcome, which can improve the quality of life. They can help the patient survive, go back to his normal vocation again. So that is very, very important. So it is only possible when we do early interventions in many of the strokes. It is estimated around 20 lakh people are suffering from stroke every year in India. And this figure is going to increase further as our population ages. There are more and more incidents of hypertension, diabetes, lifestyle diseases. As all this increases, I am sure this figure is going to become even higher in the coming decades. So it is a very, very important public health problem. Many of these stroke patients are young. You must have seen a lot of young stroke patients getting stroke in 40s, 50s, 30s. And they are the people who are struck with stroke in the prime of their life. A patient who was a breadwinner for his family becomes a burden on their family. So these sort of scenarios should not occur with our patients. We should treat them, pick them up early on time, send them to appropriate stroke center where a proper therapy can be started, which can not only reduce the mortality, but also the morbidity which is associated. A lot of patients who survive from stroke are also left with very severe neurological deficits. So they become a burden on their family. So it's not only the question of reducing the mortality, which you have to reduce the morbidity also. And this can be done by early intervention, which I will be showing you later on. It's a very costly disease, and in US it has been estimated around $1 lakh is the cost of a single stroke. As I was mentioning, it is the commonest neurological emergency due to a vascular pathology. So you have to, this is a very important thing, that stroke is not only a disease of the brain, but it's a disease which is happening because of some vascular problem of the brain. So their vessels are the culprit. There's something which is going around, either there is a thrombosis or there is a rupture. So this basic pathology is a vascular pathology which is leading to a brain problem. So whenever, this is very important why I am saying, because whenever we are treating stroke, when we are imaging stroke, we have to keep in mind that which vessel is involved. And so whenever we are doing imaging in stroke, we have to do angio also, so know which is the vessel involved, and because the different type of vessels will require different type of treatment. So any stroke, say imaging, any stroke treatment plan has to incorporate what is the status of the vessels. So this is very important. This is a very important message that whenever we are doing any imaging, we have to include vascular imaging when we are treating with a patient with stroke. More than 80% of strokes are ischemic strokes. And these are the type of strokes in which the maximum advancements are occurring in treatment. And that is why, see, many of these patients who have ischemic stroke are having a better prognosis if they are detected on time as compared to patients with hemorrhage. So as I've been mentioning about the vascular anatomy, I'll just show you some very simple diagrams of the brain which can just refurbish your memory about the basic vascular anatomy of the brain. As you all know, this pointer is working. Is not working. Okay. Over here. So this is the carotid arteries. There are two carotids, right and left, and there are two vertebral arteries. They go up, and they together form the vertebrobasilar system, the circle of Willis. Over here, you can see the circle of Willis is formed by the pointer is very light. So you can see the circle of Willis is being formed over here by the posterior cerebral artery, posterior communicating artery, middle cerebral artery, anterior communicating, and the AC arteries. So these are the arteries which form a sort of a circle. So if a stenosis develops slowly in any of the arteries, the rest of the arteries can take up the blood circulation, and many of the patients who have carotid stenosis, basilar artery stenosis are not so symptomatic. But if you get an acute occlusion in any of these arteries, then there can be a problem, especially when it is an end artery. One more important concept to understand is the concept of large vessel disease and a small vessel disease. So if a patient is getting a infarct in the artery of this caliber, see if it is a small artery which is involved, see when the arteries go up, they supply small arteries to the brain parenchyma, and if any of these smaller arteries are occluded, they are usually platelet-rich thrombi which are there, and they are smaller, size thrombus which are there. And these are small arteries, but sometimes they can also produce very severe deficits. On the other hand, if there's a proximal artery which is involved, large vessel, then they are more of thrombus, is more of fibrin thrombus, which requires different type of therapy as compared to a thrombus which is lodged in a smaller artery. So this concept of large vessel disease and small vessel disease is very important. So sometimes what may happen is a strategically placed infarct in the very eloquent area of the brain, like an internal capsule. Even a small artery can produce hemiplegia, hemianopia, and hemisensory loss, which may look like a hemispheric stroke. So not only the size, but the location of the infarct is also very important. Many of the time what happens is when you see the MRI, you see a lot of white matter changes in the brain, which are just asymptomatic. They are lacunar infarcts which the patient has been getting on for last, say, 15, 20 years, but still patient never developed any hemiplegia because they were in the non-eloquent area. But a single strategically placed lacunar infarct in a young adult may destroy his life. So the size of the vessel, the location of the infarct, all these matters a lot in brain. So this concept also is very important. So because I was mentioning that stroke is a vascular disease, so we have to have some idea which part of the brain is supplied by which part of which arteries. So if you see this yellow portion is being supplied by the anterior cerebral artery, which is a branch of the internal carotid. The red one is the middle cerebral artery, again a branch of the internal carotid. The blue one is from the vertebrobasilar system, the posterior cerebral artery, which are the end arteries of the vertebrobasilar system. and the rest of the brainstem is being supplied by the vertebro-basilar system. So the stroke manifestation will all depend which part of the brain, which part of the circulation is involved. Anterior cerebral artery, in fact, will present differently, middle cerebral artery will present differently, and I will just briefly touch upon these aspects also later in my slides. So this is how the blood supply to the brain looks like. This is a very simple diagram, so we can remember it, how which part of the brain is supplied by which arteries. The brainstem again is supplied by the vertebro-basilar system. The two vertebral arteries are uniting at the lower border of the pons over here, and they form the basilar artery, and the basilar artery at the top is dividing into two posterior cerebral arteries, which I showed you in the blue part, which is supplying the occipital lobes. And this is already a slide I've showed you, that this is the concept of the large vessel disease. If suppose the thrombus is lodged over here, the large vessel is occluded, or if over here, this is a small vessel. So it makes a hell lot of difference in the treatment. So whenever we are doing any imaging for stroke, so not only we have to look at the brain, we have to look at the arteries also. This is a very, very important point you have to understand. So how does stroke present? Stroke has got a very classical presentation. It's like a bolt from the blue. Patient 2 મિનિટ પહેલા બિલકુલ સારું હતું, અચાનક બોલવામાં તકલીફ થઈ ગઈ, હાથ પગ નથી ઉપડતું. So this is a very classical presentation. Patient having like a hemispheric stroke, suddenly they develop left-sided weakness, right-sided weakness, along with inability to speak. So this is a classical presentation of a large hemispheric stroke in carotid artery circulation. Patient suddenly starts developing ataxia, vomiting, diplopia, very classical presentation of vertebro-basilar territory. So it's an acute onset. So most important thing to understand is that this is a bolt from the blue. Patient was absolutely fine few minutes back. Suddenly he has developed this neurological deficit. This, if you get this history, immediately your antenna should go up, your alarm bells should start ringing that this patient is suffering from stroke. It may be early stroke, window period. We have to manage the patient urgently. As I've told you, the neuro deficit will depend on the territory which is involved. So in carotid disease, carotid circulation, mostly they present with hemiplegia, hemianesthesia, hemianopia, speech deficit, change in their behavior, aphasia. All these are common in carotid artery disease. You have to understand that this size of the vessel which I was telling you is also very important. Some patients may just present with very minor deficit. They suddenly start having difficulty in writing. They are not able to write only. Their arm, they are able to lift their arm. They are able to walk properly, speak properly, only mild deficit in writing. So that also may be a stroke. Patient gets a stroke, dies at home only prior to receiving any treatment. It can also be a stroke. There is a whole vast spectrum of severity of stroke. A patient gets a brainstem hemorrhage, will die before reaching the hospital. A patient with a very mild stroke may be totally asymptomatic. There may be very minor deficits. So all this is stroke. Sometimes you can just see a patient who's never complained of any neurological deficit. When you do MRI, you find there are so many lacunar infarcts spread throughout the brain. So all these are asymptomatic. So many a times stroke may be totally asymptomatic. Suppose a patient gets an infarct in the prefrontal lobe. Patient may have some problem in understanding. Patient may have some problem in judgment, which also may be very minor. The patient never pays any attention. So stroke can be very mild, asymptomatic, to a severity that patient may die at home before reaching the hospital. So there can be a whole spectrum of severity of stroke. And all the manifestations will depend whether the carotid artery is involved, vertebro-basilar system is involved, which is the size of the vessel, how acutely it has happened, and whether it is a ischemia, whether it is a hemorrhage. So all these will decide the clinical picture. So any part of the neuroaxis may be involved, and depending on which artery has become involved, which vessel has become, what level, how fast, it will all decide the clinical features. So the deficits can range from asymptomatic, mild to catastrophic. As I mentioned, luckily more than 3/4 are ischemic stroke, and this is the place where the most of the the advancement in treatment is also happening. There are some things which can also produce, as I told you, the clinical hallmark of stroke is the acute presentation. Patient develops any deficit very quickly. Within few minutes, few hours, the patient is developing the neurological deficit depending on the territory which is involved. So there are some other, things also which can present very acutely. So what are those? These are the what is known as stroke mimics, which may look like a stroke but may not be a stroke. So in this case, if you take a proper history, you do a proper examination, you will be able to at least identify many of these patients because they have some things in the history which can help you to find out which patient is suffering from stroke or from stroke mimics. But there are sometimes when we are not able to do so, and then we have to rely on the investigations. So most important thing which resembles a stroke, which can be most close mimic of stroke, is migraine aura. So many of the patients who suppose develop migraine aura for the first time, they suddenly lose their vision, or they are getting tingling numbness, or they are not able to speak really. So all these things which is happening acutely and lasts for a few minutes or few hours and then becomes okay, maybe look like typically like a TIA. It's very difficult if the patient is getting this episode for the first time to say clinically whether it was a TIA or a migraine aura. There may be a headache which is associated with migraine aura, but you can have many other strokes also in which you can get headaches. So just because there is a episode in which headache was present, we cannot just say it was a migraine aura. In first episode, we have to do imaging. If the imaging is normal, there is no presence of any infarct, etc., then only we can say that this patient was having headache plus this neurological deficit. Most of the time, the deficit is a visual aura, visual blurring. So if that typical scenario evolves and then later on patient keeps on getting this same episode, then we can say retrospectively, okay, this was migraine. But see, in the first episode, you have to do a proper imaging, rule out a stroke, then only you can label this as. So in first episode, never label migraine aura. First you do a proper imaging. Then TOTS palsy. So there is a question, this question carries a prize. Who can tell me what is TOTS palsy? This is a prize. Tell me. Absolutely right, madam. One prize for you. Please, your name? Santosh? So absolutely right. So this is a TOTS palsy is a paralysis occurring after a seizure. So if a patient has got a focus in the brain, suppose in the left frontal lobe, and patient gets a seizure because of left frontal focus, then when the patient recovers, becomes conscious, he may be left with right hemiparesis because that part of the brain which had this neuronal hyperexcitability, then later on goes into what is known as neuronal hypoexcitability. Then the patient develops a weakness on that side. So if this patient's weakness, good thing is that it will resolve within 48 hours, less than 48 hours. But then there should be history of seizures. There should be history that it passed, there was some lesion over there, or gliosis or whatever, and this patient has developed a seizure. After that, within 48 hours, the patient improves. But also, as I'm mentioning, with migraine, if you have first episode of weakness with seizures, before labeling as TOTS palsy, you should do a proper imaging, rule out there is no stroke, do a EEG, document that there was a seizure, then only you can label it as TOTS palsy, not for the first time. This is very important because we can miss out some stroke just by saying it was a TOTS palsy. So that should not happen because it can be a life-threatening situation for the patient. Sometimes hypoglycemia also can present with focal symptoms. Subdural hemorrhage also may present with focal symptoms, especially with weakness in the legs. So that can be an acute history. But if you take proper history in both hypoglycemia, subdural hemorrhage, if you take a proper history, you will find the onset is a bit more slower and there is more of confusion as compared to a patient with a stroke. Encephalopathy is more as compared to focal signs in these two conditions. In stroke, if you have a small stroke, usually patient will be fully conscious alert. In hypoglycemia, subdural hemorrhage, there will be more of confusional state. Meningoencephalitis, if you take a proper history, then I think there should not be a problem. Sometimes what happens is due to meningoencephalitis also you can develop what is known as vasculitis. And then patient may develop a stroke. But this time the stroke has got a different, it's not like a typical diabetic hypertensive type of vascular pathology. It is arteritis because of the vasculitis which is associated with the infection. This is a inflammatory arteritis which is happening. So this is a different type of thing, but it is also leading to a stroke. As I told you, stroke can happen because of vascular pathology. So this is also a type of vascular pathology, but a different one as compared to what are the garden variety of the stroke is. So these are the main type of other etiologies which can mimic a stroke. If you take a proper history, most of the times you will be just able to diagnose stroke clinically only. But whenever in doubt, better to do a imaging, better to rule out a stroke by a proper imaging rather than leaving the patient alone. Now let's come to very, very important one more concept is the reperfusion and the penumbra. As I was telling you, one of the very important thing for you to understand is that stroke is because of a vascular pathology. Then whenever stroke is happening, what is happening is that when the vessel gets occluded, there is a part of the brain which is at the center of the infarct, which is over here. This is known as the infarct core. This is the part which we cannot rejuvenate. Even if you reperfuse, it will not come back to life. It is part which is dead, gone, infarcted at the very outset. So this is the part which is being supplied by that particular artery, which is the end artery for that segment. And no matter what you do, even Mr. Trump gets a stroke, this part is not going to recover. Because, as you know, neurons have got only a reserve of 4 minutes of oxygen and glucose. So within 4 minutes, nobody can receive a reperfusion therapy. So this part of the brain is dead and gone. We cannot salvage it. So all the focus of the stroke therapy is on the periphery of this, which is known as the penumbra. So this is the part which at the moment in the window period is oligemic. It is injured but not dead. So this is very important because this is the one which is producing most of the symptoms. So if a patient gets a sort of middle cerebral artery occlusion, he presents with hemiplegia, hemianesthesia, hemianopia, aphasia. All these things are there, but when you see the infarct is smaller because this part is not functioning because of the oligemia. It is hypoperfused, so it is not functioning. It is producing the neurological deficit, but at the moment it is salvageable. It is not dead. So this is the part of the brain which is surrounding this umbra, which is known as the penumbra, is the part which we are aiming to restore, revive, and prevent from being dead. So this is how the concept you can see radiologically. So this patient who has come in the window period, so has initially an infarct in this part of the brain, which part is this? This is the gangliocapsular region in the brain. This is the diffusion weighted imaging. You can see a small infarct over here. This is the ADC mapping again. Again it shows a black signal over here, which is corresponding to this white signal. So it's an acute infarct. And if you see the imaging, so you can see this imaging over here, this is the right middle cerebral artery, which is very well seen. But over here you see there is an occlusion of the left middle cerebral artery. So if you see, this left middle cerebral artery is supplying this whole hemisphere over here. But at the moment, the infarct is just over here. So this part of the brain is at the moment hypoperfused, and actually it constitutes what is known as the penumbra, which I showed in you the last slide. So this is the brain which is in the penumbra region of this cerebral artery occlusion, middle cerebral artery occlusion. And if we don't intervene on time, what will happen is, if you just image this patient after say 1 day, what will happen is, see this middle cerebral artery which is still occluded, and you see the infarct what has happened. See, this was small infarct over here, but now you see the size of the infarct which has increased. So this patient who came if suppose had come in the window period, received appropriate therapy, we could have prevented this infarct from going into this. So that is what the rationale of all these evolving therapies is there, that to prevent this from converting into this. Many of the patients are reaching to us on time, and we have to pick them up early and institute the proper therapy so that this can be prevented. And suppose if you are able to prevent this, many of the patients will not only survive, will go back to their normal activities of daily living, they will become a functional person again. So this is what the entire, see why I keep on barking in every session over here, is that because we don't want these patients from becoming over here, coming from here to here. We have to intervene over here. So this is what all the exercise is about. So what should we do? We have to be fast. So any patient who has developed, this acronym stands for facial palsy, any patient who has acute onset drooping, any problem in holding objects, falling down of arm, weakness in the arm, any problem in speech, S stands for speech. So this, and any problem who has got, any patient who has got lot of loss of balance, acute loss of balance, loss of vision. So this is the whole acronym, be fast, balance, eyes, face, arms, speech. Any of this problem is there, which has an acute onset, suspect stroke, and time is very important, as I'm telling you. All these things are very, time-bound things. We have a very short window period. We have to pick the patient on time, send the patient in the window period. Then only any of the following therapies which I've been telling you about can work. So this is the place where you people have a very, very important role. So it's up to you. If you send the patient to us on time, then only we can prevent the infarction size from increasing and patient coming back to full normalcy. It can happen only if you pick the patient on time. So any patient who is calling you saying that I have developed sudden onset weakness in the arm, sudden onset difficulty in speaking, loss of balance, loss of vision, change in speech, don't ignore, especially if it is a focal sign. Only one hand is involved, only one leg is involved. So these are not signs of generalized asthenia. Many of the patients keep on complaining to you, "Hamare to haath pag mein nabdai jeev lage chhe." But if it is acute, one-sided, you have to see, because see, every time, whole day, I think you must be receiving 15, 20 calls, "Kam nabdai lage chhe, kamjori lage chhe." So this should not be ignored if it is focal, acute onset. So this is very important to pick up these type of things to, what I can say, to find out the real signal from the chatter, the background chatter. So we have to be very careful, listen to the history. If the history is still very, very important in medicine, especially in neurology. Dr. Timbadia, you agree? Okay, so history is very important. So, as I was mentioning, we have picked up the patient on time. We think that it's a stroke. Then what should we do next? If the patient is stable, then there are two options. Either you send the patient to a stroke center, which everything is under one roof, like in our New Wins Hospital, what we have done, we have got an in-house CT scan, MRI, in-house cath lab, everything is in-house. So basically, why we have come up with this concept of having an in-house CT scan, MRI, putting up so much machines and all those, is because the window period is short. So we cannot waste the window period. So there is an importance of doing early intervention. So either you send, if you are suspecting that patient is having a stroke, to a center which has got in-house CT scan, MRI, or you tell the, if the such type of facility is not there, you can send the patient to a radiology center, which can take up this patient in time, as fast as possible, and provided that the patient is stable enough to go to a radiology center. Because if the patient is unstable, not having proper breathing, secretions altered, then better to send, hospitalize the patient, stabilize the patient, and then you send her for the imaging. And as I was mentioning, stroke is a vascular pathology. So whenever we are imaging, we are not only doing an MRI, we are also doing an angio. MR angio or CT angio, depending on whatever is available. Best is MR angio, because you can see the infarction also much more early in MR angio as compared to CT angio, because CT scan does not pick up the infarction very early. Hemorrhage can be picked up very early in CT scan, but the infarct takes time to evolve and appear on the CT scan. If the patient you feel that has doubtful whether patient is a really stroke or a stroke mimic, then you can do first MRI and you rule out that there's no meningoencephalitis, there's no subdural hemorrhage, there's no SOL. So then, if required, you can supplement it with an angio. If it comes out to be a stroke, or you feel that it could be migraine, then maybe you can do an angio also in that patient also. So if you are doubt, maybe you can do an MRI. If you are no doubt, you send patient straight away for MR angio, because I will be telling you why we are doing so. So now I will show you some cases which we have done at our hospital. And you can see this patient. Now this patient came with, see this patient is a 68 years old male, presented with left hemiparesis since 8:30. He has reached to us within 2 hours. Patient also had a past history of CBA also, but he has stopped treatment. He had a left-sided weakness. See, this patient is not able to lift the arm. See, you can see, the arm is falling. You can see. So this patient's NHS score was around 12. He had stopped all the treatment. So what we did, because the patient had come in the window period within 2 hours, we did a scan, and the scan was revealing this old infarct which is there in the right MCA territory, but there is a new infarct also over here. The patient was not very affording. So what we did, we went ahead and did a thrombolytic therapy in this patient. If you see, there is a stenotic lesion in the right MCA over here. There is a stenotic lesion. So most probably there was some artery-to-artery embolism which was going from this artery into the distal territory. So this patient was thrombolized. We are using TPA or tenecteplase, but most of the time now we are using tenecteplase. And just see what is the result. So after day 8, the patient is walking, power is also improved in the arm also. He's walking in a corridor. Now let's come to case 2. Now this patient presents with left hemiparesis with power of 3/5 since last 1 hour. Her scan was done, which revealed the acute infarct in the deep right MCA with right MCA occlusion. Now just see in this scan what is we can see. See, I showed you one slide earlier in which the left MCA was occluded and there was a complete infarction which involved after 24 hours. But in this case again you can see there is an occlusion of this right MCA. You can see this left MCA over here, and this right MCA is completely non-visualized. So this is the infarct which is seen in the deep right MCA territory over here. Now again you can see this artery is a very big artery, and it is supplying whole this part of the hemisphere. Whole hemisphere is being supplied by the middle cerebral artery, but there is infarct is much smaller. So there is a huge penumbra which is still there. And this patient again has come to us in the window period. Actually this was a relative of one doctor, actually a neurologist in Gujarat. So this patient had come to us. So we said that let's go ahead and do a mechanical thrombectomy in this patient. But because the patient's relative was insisting that first we thrombolize, so we thrombolized, but we knew that there will be some chances of recanalization are less. So we shifted the patient immediately to our cath lab and did a DSA later. So this patient was thrombolized, but the patient's power, neurological situation did not improve. Why it did not improve? Because, see, when we thrombolize by all these chemical agents, what happens is that the chances of recanalization are very low. Because as I was telling you, the importance of the large vessel and the small vessel, as I told you. So the small vessel, they have got platelet-rich thrombi, etc., which can easily lyse with thrombolytic therapy. Smaller, say, thrombi lodged in distal vessels, like if suppose a thrombus is lodged over here, if we give TPA or tenecteplase, the chances of recanalization is 73%. It can easily lyse. But if a thrombus load is large and is situated proximally, you can achieve a reperfusion with TPA or tenecteplase in only 14-15% of cases. So this is what exactly had happened to this patient also. So despite giving tenecteplase, this patient had not improved. So what should we do now? The patient is not improving, so we should give injection dexamethasone, thrombolize the patient again, do a thrombectomy, or do a carotid endarterectomy. So again, a price question. Mechanical. So Dr. is first, fastest finger. Dr. Arun Agarwal. So we have to do a mechanical thrombectomy. So this is exactly what we did, and this is what here the cath lab video is like. So this is how. So this patient was taken up in our cath lab. If you can see, there is no artery seen on the right side over here, and then this catheter was passed, and then the device is passed later on, and this thrombus is sucked out, and then check shoot is taken later, and you can see so this was the occlusion, and now you can see the perfusion over here. See, all the right-sided arteries have come back by the thrombectomy. This is the thrombus which was aspirated out from the artery, you can see. So the thrombectomy goal is that, see, we have a normal vessel, it gets occluded, then we have to take out mechanically this thrombus. There are many type of devices. You can see this video, how these devices work. Sound is there. You can hear the sound. Sound. So this patient has suffered from a large vessel occlusion, and this patient is being volume बढ़ा दो.
एक second.
Not coming.
वायर कनेक्ट नहीं हो रहा
No. So this is a thrombus which is lodged in the middle cerebral artery. So it is patient is taken up in the cath lab. We go from the femoral root, go up, pass the guide wire first, cross the thrombus, so Dr. Dinesh is not there, so I will be covering up. So my lecture will go on for longer period. Don't worry, your lunch will not get delayed. So this is the device which has been now inflated now, and we have captured this thrombus, and now we are going to pull it out, and the reperfusion is restored. So this cerebral circulation has been restored. So this is how this device works. There are many type of devices which are there. So we should understand that when we do mechanical thrombectomy and when we do thrombolysis. Say mechanical thrombectomy is quite expensive. In our center, it costs between 6 to 8 lakh rupees. But if you go, as far as when I go down southwards, the cost goes northwards. I have seen one patient getting a bill of 32 lakh in HN for the same procedure which we are doing in 6 to 8 lakh over here. So there is, so we have to use thrombolysis as far as possible, but at the same time you have to understand that the patient's recovery is more important. See, at the outset, the 6 to 8 lakh may look very hefty amount, but if you see in the long run, a person who suppose is struck in the prime of his life will not be able to earn whole life. So better to spend at this onset rather than becoming a burden on the family. So what are the indications for thrombolysis? If the patient has come within 4 to 4.5 hours, within 4.5 hours, there is a small vessel occlusion or a vessel which is distally placed, which is like an embolic stroke, small stroke, then the chances of this patient recovering by thrombolysis, chemical thrombolysis, are high. Then we should do this. On the other hand, if patient comes after 5 hours, there is a large vessel is involved, the patient is already taking some anticoagulants. A lot of these our patients are now on these newer anticoagulants, you know. So if these patients who are taking newer anticoagulants, you give them thrombolysis, they will bleed like hell and die on the table, and then the doctor will get sued. So if a patient has suppose a liver disease, his PTINR is high, we cannot risk a thrombolysis. If a patient had a recent surgery, trauma, all these things are contraindication for chemical thrombosis, then the mechanical thrombectomy is the only option. So now the indications for thrombolysis are becoming less and the thrombectomy are becoming much more. But at the same time, given our economic situation, we have to be always inclined towards chemical thrombolysis. If the patient can afford it, then better to go for mechanical thrombosis if a patient has got especially a large vessel occlusion. So sometimes what we do is thrombolize the patient and then take him up for a DSA. If suppose reperfusion has been achieved, best. If reperfusion has not been achieved, then we can go for a mechanical thrombolysis. So this also is known as bridging therapy, which can also be done. First do thrombolysis and see if patient is responding, best for the patient. Not responding, then you can offer mechanical thrombectomy to these patients also. So these two cases illustrate something which we are doing in the window period. There are some other interventions also which we are doing for some other patients. There are some very interesting patients. I will come to them now. Now, this is one of Dr. Dinesh's patient. Now just listen to his history. So this patient, if you listen to his history, then what he's saying is that he's losing vision again and again is the left eye. So this patient had gone to 2-3 ophthalmologists. Everybody said it is fine. He went to some other doctors who get an MRI brain done. It was also normal. But still, this patient keeps on getting these episodes again and again. So this patient was suffering. This is the MRI of this patient, absolutely bang normal. This patient is suffering from a disease which is carotid stenosis. So this patient had a very severe left carotid stenosis. So from here, the emboli was going again and again into his retinal arteries. And he was suffering from a syndrome which is known as amaurosis fugax. So this patient was getting these episodes of loss of vision in the left eye from this emboli which was occurring in the from the left carotid stenosis. So this patient, we did, when we saw the patient, took the history, then there was strong suspicion of amaurosis fugax, and then we did the angio, and the angio was showing a severe carotid stenosis, and this patient was stented. So this is a pre-stent video. You can see the severe carotid stenosis is there. Then we are doing the procedure, guide wire has been passed, then the stent. So you can see the stent over here. This is a stent which has been placed. So carotid artery has been opened up, and we get very good result. And let's see, listen to the patient history. Now what is he saying? So all the episodes have gone. So carotid stenosis can present in some other ways also. Let's see one more interesting. Now just see what is happening to this lady. It's falling off. Laptop is falling off. So this patient, if you can see this patient in this video is getting these repeated episodes of these abnormal movements on the left side. Like, so this patient keeps on getting these abnormal movements which look like chorea. So this patient also, thank you. So this patient is an elderly patient who has diabetes, blood pressure, all these risk factors are there. And there is no neuro deficit apart from this abnormal movements. And when we do this imaging over here, we find there are infarcts which are there in the right MCA territory. And there is a stenosis over here, which you can see in the right MCA. So this patient was getting these, what is known as limb shaking TIAs. This is the stenosis over here. So this patient was getting a limb shaking TIAs from this carotid stenosis because of the hypoperfusion, which was occurring very frequently. And this is the procedure which we did in this patient. Again, stent has been placed. Patient gets a very good recovery. Carotid stenosis may also present with hemispheric stroke. This is artery-to-artery embolization. Patient may land up into hemiplegia, aphasia, depending on which side of the patient's circulation is involved. So these were two interesting patients of carotid stenosis. Now let's see one more case. This is a 54 years female who has presented to us with complaint of diplopia and headache for last 2 days only. And this was followed by ptosis. The left eye fell down. The eye became closed. So on examination, there was no other finding. Everything was absolutely fine, except that there is a complaint of headache with diplopia. There is no past history of migraine. There was no sinusitis, no other significant history at all. When we examined this patient, there was no other deficit, and the patient's pupil was dilated. Left pupil was dilated. So when a patient presents to you with this history of ptosis with a dilated pupil, what is the common cause? Yes, Dr. Saab is right. Dr. Yogesh, absolutely right. So this patient is suffering from a third nerve palsy because of a compression. What is the commonest cause of third nerve palsy? The commonest cause of third nerve palsy is diabetes. But the thing is that, see, in diabetes, usually the pupil is spared. So if you get a third nerve palsy with pupillary involvement, so it should immediately ring a bell in your mind that this could be a very, some catastrophic thing which is evolving. And most commonly, the third nerve with a dilated pupil is because of a compression due to a aneurysm. So this patient was subjected to a angio, and this angio over here shows a outpouching over here. See this over here. So it is a aneurysm from the internal carotid artery which is pressing on the third nerve. which is presented with a painful third nerve palsy with dilated pupil. So dilated pupil in a third nerve is always very, very important, and it should be a thing which we cannot ignore. Do urgent imaging, including a angio. So in this patient, there was an aneurysm which was there. So at this moment, she has got only a third nerve palsy. But if we don't treat this aneurysm, what can happen? Patient may develop a catastrophic subarachnoid hemorrhage, and patient may die. So patient who is presented with third nerve palsy is coming to you with an early sign. So you have to pick it up early and do the appropriate imaging and do the appropriate therapy. Otherwise, the patient may die of a severe subarachnoid hemorrhage. So this patient, again, was taken up in the cath lab, and we have done a procedure in our hospital in which you can see this aneurysm which is there, very beautifully seen over here. I can just run back the video. It will come. See, this is the video. This is the part which is the aneurysm. So you can see a large outpouching was there. So we passed the guide wire, and now we have filled it up with what is known as titanium coils. So this is a coiling which was done over here, and this, because of this coiling, the aneurysm gets occluded, and it cannot rupture, and it cannot cause subarachnoid hemorrhage. The third nerve palsy will take time to improve, but this is something which we can do, which can be life-saving if done in the right time. Now let's see one more patient who had also aneurysm, but they present very differently. A 52 years male presented with focal seizures with left hemiparesis, and there were some abnormal movements on the right side also. So this patient had sudden onset hemiparesis, altered sensorium, focal seizures, coriform movements, all these things were there. And again, there was a very sudden history. Compared to ischemic stroke, this patient had a different type of hemorrhagic stroke. Patient had a very bad respiration. We had to stabilize him first, and then on the vital examination, BP was very high, pupils were reacting, there was left-sided extensor response, left hemiplegia. So this patient was subjected to a CT, and CT angio, they showed a subarachnoid hemorrhage. So this is the subarachnoid hemorrhage which is present, which is leading to, this is a right-sided bleed, so it was causing left-sided hemiparesis with left-sided focal seizure, altered sensorium, and this is the aneurysm which was seen in the CT angio. This is a MC aneurysm, MCA. So this patient was not so affording. So this patient was taken up for a surgery, and when we did the surgery, there was an aneurysm which was found, and it was clipped. So rather than doing coiling, the patient was opened up, craniotomy was done, and this is the aneurysm which you can see, the neck, the clip has been placed across the neck, and this is the how we have occluded the aneurysm. So we have clipped the neck of the aneurysm so that the aneurysm is no longer a part of the circulation, blood is not going inside, so even if whatever happens to the aneurysm, it is not going to cause subarachnoid hemorrhage anymore. So this is a surgery which has been taken up for this patient. So what happens is that many of the patients are not able to afford surgery, coiling, because coiling is quite expensive. Titanium, all those coils, each of them costs around 70, 80,000. Sometimes you require 5 to 6 coils. So the cost of the intervention, coiling, is a bit higher. So many of the patients who are not able to afford, or sometimes you have a hydrocephalus, etc., then you have to go for a surgery. So the indication of coiling versus clipping is that for coiling, most of the times if a patient is unstable neurologically, patient is high risk for any anesthesia required for surgery, then better to go for coiling. Advanced age, suppose the surgeon will not able to reach the aneurysm site very easily. Like if you have a basilar tip aneurysm, ophthalmic artery aneurysm, so the surgeon will have a lot of problem in accessing that size. And then patient will get a problem because of the retraction of the brain, then it's better to go for a coiling for these aneurysms which are placed very inside, the deep inside, which are not very easily accessible. The size, if very large, then we go for clipping. If the size is smaller, we can do coiling. Because see what happens is that if the very wide neck is there, if you put the coil is going to come out. So for smaller aneurysm, you can do coiling, but larger aneurysm, you require a clipping. So the indications for clipping are, patient has to be symptomatic. We cannot do clipping for asymptomatic patients, which are discovered many times on angio. If you have a aneurysm which is situated in the commonly accessible site, ACOM, PCOM, MCA, which are easily accessible for the surgeon, then we go for clipping. If aneurysm size is big, then it's better to go for clipping, because see, as I was telling you, the cost of the intervention keeps on increasing. The more the size of the aneurysm, more coil will be required. If it is a very wide neck, what will happen is that if you put the coil is going to slip back. It is not going to stay. Then you have to do one thing more, which is known as flow diverter, which increases the cost even further. So therefore, in aneurysms which are of very large size, we usually prefer clipping. So these are some of the common interventions, some of the common things which we are doing for stroke. We have established this new center in Borivali, where all these facilities are available in-house. We have in-house CT scan, MRI, in-house cath lab, in-house OT, stroke unit, everything is there in the in-house. So this center is basically tailored for neurological patients who can reach to us in window period and avail all these newer therapies which we are been showing in our talk over here. So this is a center, unique center in our western suburbs with all the facilities for these type of patients. You are most welcome to support us, send your patients so that they get a good outcome. We are eagerly waiting for your support. And if there are any questions regarding my talk, I hope I have given you some information which you find informative, of use to you in day-to-day practice. And I also thank BMB, Paresh, Jignesh, Rajesh, everybody for giving us this opportunity to be associated with you. It's been always a pleasure to be associated with BMB and be associated with your programs. And I hope you will be giving us opportunity in the future also. Thank you so much. I hope everybody has enjoyed my talk, other talks, all the scientific sessions which were going on, and the whole conference per se. I really appreciate your support to us also, and we will always be supporting the BMB in the future. Thank you. Thank you, Paresh.
Thank you, sir. Thank you.
Thank you so much. Our request, किधर है? Paresh sir, आइए please. To please felicitate Rajani sir. Our request, Secretary Minal, Chairman, Ashish Modi sir, Chaya ma'am to please join us stage. Dr. Kinjal Modi, please. First, small move as a speaker. Please, Pragati here. First, sir, please. Go. Thank you, sir. Digi, aja. Come. आप अच्छी आप आया नया उजाला 4 बूंदों वाला हो जाएगा अपना. Thank you. Okay, one more. ये नहीं अपना मोमेंट हो. Yes sir, कर मैं लेता हूँ. Okay, this is for being our platinum sponsor, New Wins Neuro and Multispecialty Hospital sir. Huge round of applause for New Wins Hospital. Yeah, they are our platinum sponsor for MEDIMEET 2026. Thank you sir. Okay. One more. Chairman sir, Ashish. सर यस सर आपका लेके आइए सर कैसे करेंगे संतोष प्लीज थैंक यू रिक्वेस्टिंग होल कम्युनिटी टू प्लीज जॉइन ऑन स्टेज एवरीवन प्लीज फटाफट क्विकली होल कम्युनिटी टू प्लीज जॉइन ऑन स्टेज आइए सर आइए बता प्लीज राइट સર આવી જાઓ સેન્ટર. હા ખબર છે આવી જાઓ ને બોક્સ આવે ત્યાં સુધી બાકીનું અરેન્જમેન્ટ કરી દઉં ને. સર નમન શર્મા સર. दीजिए आपका लकी ड्रॉ. आप क्या लेके आए बोलो पटारे में वो बताओ पहले. अरे बहुत सारे गिफ्ट दिख रहे हैं उसके अंदर. ओके ओके, विल स्टार्ट विथ यू ओनली सर. एक निकालो सर, बाकी के फिर हम निकाल देंगे सर. उसके के पकड़ 3 बहुत सारे गिफ्ट है उसके अंदर, मैंने देख लिया. डॉक्टर नीता नाटकर्णी, या मैम प्लीज कम फॉरवर्ड प्लीज. अरे वो प्लीज कम जी सर, आइए मैम. नेक्स्ट मैम. हाय हाय. Next coming up is lucky draw winner डॉक्टर किंजल मोदी. सो वो नहीं लेंगे, वो हमको देंगे. हाँ, तो मैं स्टॉल पर गया था. नेक्स्ट सर तमें. ओ हरेश सर, डॉक्टर हरेश टिम्बाड़िया. ही इज नॉट देयर. किसी को और मौका मिलेगा. हाँ तो मैं क्या करूँ? तू आपने हाँ क्यों बोला? नहीं नहीं.
डॉक्टर अरुण अग्रवाल. डॉक्टर भूपति. So Dr. Saab, we will be giving you at your seat only, हाँ? नहीं वो डॉक्टर तिम्बाड़िया का था, वो क्वेश्चन वाला भी दे देंगे उनको, दोनों स्पीकर को दे देंगे. क्वेश्चन आंसर वाला उनको दे देंगे. हाँ? नहीं सॉरी, नहीं वो इसका हो गया.
ओके सॉरी सर, हमारे पास से आएगा, टेंशन मत लो. ये हो गया. ओके सो टाइम टू से गुड बाय. बिफोर दैट इफ यू हैव लाइक्ड मेडिमेट 2026 देन काइंडली, ये टीम के लिए बहुत जोर से तालियां बनती है. स्टैंडिंग ओवेशन बनता है कि नहीं बनता है? या देयर यू आर. ओके सो आई रिक्वेस्ट द प्रेसिडेंट एंड चेयरमैन टू प्लीज कम फॉरवर्ड. चेयरमैन किधर है? ओ चेयरमैन सर आगे आइए प्लीज. आई रिक्वेस्ट प्रगति प्लीज कम ऑन स्टेज. विल लाइक टू स्टार्ट विद द फेलिसिटेशन ऑफ ऑल आवर कमिटी मेंबर्स. तो कोई भूल जाओगा तो प्लीज बता देना. ओके विल स्टार्ट विथ डॉक्टर मनीष सर. मनीष सर प्लीज आगे आइए. आई रिक्वेस्ट फटाफट एक सिंगल क्लिक में फोटो फटाफट, सबको बहुत ज़्यादा भूख लगा हुआ है. हाँ आशीष भाई आगे आओ. तालियां बनती है अगर अच्छा लगा रहेगा तो. लकी ड्रॉ बाकी है, गोल्ड कॉइन बाकी है, सिल्वर कॉइन बाकी है. 2 गोल्ड कॉइन, एक गोल्ड कॉइन, एक सिल्वर कॉइन है. 3 लकी ड्रॉ गिफ्ट मुझे वहाँ पे दिख रही है, जहाँ पे एक हेयर ड्रायर है, एक माइक्रोवेव, एक हॉट प्लेट है. नेक्स्ट कम्स डॉक्टर अवंती त्रिवेदी. नेक्स्ट इज डॉक्टर जिमी देसाई, आर साइंटिफिक सेक्रेटरी. थैंक यू मैम. डॉक्टर सारिका क्विक. डॉक्टर सारिका कटकुरी प्लीज. नेक्स्ट डॉक्टर तेजल पांचाल. उधर से पीछे आ गई. डॉक्टर प्रीतेश किधर है प्रीतेश? हाँ डॉक्टर तेजल पांचाल बोलो, घरे जवान છે મારે પાછું હવે તમે શું. डॉक्टर प्रीतेश गोगरी. डॉक्टर धारणा. डॉक्टर SN त्रिवेदी. हाँ अब धीरे धीरे पीछे पीछे क्यों जा रहे हो? ये कल से यहाँ पे से मार्क करूंगा मैं ऐसा, इस पे खड़ा रहने का. डॉक्टर SN त्रिवेदी सर. डॉक्टर लता मेहता. लता मैम. डॉक्टर मनोज रजानी सर. Now the time to felicitate our office bearer for MEDIMEET 2026. Thank you, sir. Round of applause for our convener, Dr. Chaya Bangera, ma'am. Please, ma'am. Thank you for this wonderful medical conference, our 11th scientific conference. Our secretary, Dr. Kinjal Modi, sir, for MEDIMEET 2026. and our organizing chairman, Dr. Ashish Modi. Thank you, sir. Thank you. Okay, now, एक मिनट sir, Ashish sir. The theme was for AI. So you are AI person. So we like to have a 2 or 3 tips how to use AI. और પછી નહીં પતે નહીં પતે ભાઈ પતાવો તમે નહીં પતે સર તો તમે રેડી કરો ત્યાં સુધી ઓકે નાउ आर ऑफिस स्टाफ आर बैकबोन आएगा 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 मुझे पता है उसको अलग कैटेगरी में डाला है मैंने मजदूर कैटेगरी में डाला उसको आर ऑफिस स्टाफ मिस्टर राजकुमार राजकुमार जी राजकुमार के लिए तालियां बनती है आपके फ़ोन उठाता है नहीं उठाता है या लीना वेयर इज लीना लीना प्रगति अनगांव थैंक यू प्रगति आप हमारे एमएमसी पॉइंट एप्लीकेशन प्रगति ने किए हैं तो उसके लिए जोरदार तालियां बनती है एंड नेक्स्ट फॉर होल अरेंजमेंट एट नोवोटेल हमारा जो भी स्टे इतना कंफर्टेबल हुआ हमने जो इतना अच्छा खाना खाया हमारा चेक इन एंड चेकआउट उतना अच्छा हुआ एवरीथिंग सो किधर है किधर है किधर है किधर है तो को बुलाया मैंने मिस दिव्या गोगरी प्लीज दिव्या प्लीज कम दिव्या का दिमाग हम 2 महीने से खा रहे हैं कि भाई हमको नोवोटेल का डील करवा के दो अच्छे रेट में एंड शी हैज़ डन ऑल दी वर्क फॉर आवर वेन्यू ऑल अरेंजमेंट ऑल कोऑर्डिनेशन ऑल फूड एवरीथिंग शी हैज़ डन सो थैंक यू दिव्या हमारी गालियाँ खाने के लिए और काम करने के लिए सर प्लीज एंड विल लाइक डॉक्टर नमन शर्मा टू प्लीज ज्वाइन आ जाओ आई एक किसी का रूम का बाकी है चेकआउट तो नमन को भी बता दो फिर वो अपने फाइन लेता हमारे पास से ओके Thank you. Now to felicitate our BMB office bearer, first coming is our immediate past president, Dr. Jignesh Mehta. Please, sir. आओ. आशीष भाई क्यों पाछा बह जाते मैं घड़ी घड़ी नेक्स्ट इज माई सेल्फ डॉक्टर राजेश बांसल तो मेरे को भी दे दो Next is our secretary, Dr. Minal Banchal. Please. ये चेंज कौन किया चेंज कौन किया पीपीटी पीपीटी वाओ ऑडियो विजुअल अरे हाँ हाँ And the next, Dr. Paresh Mehta, our president. जोरदार तालियां बनती है सर के लिए हम सब मिलके सर को देंगे आ जाइए सर आप आइए प्लीज आगे हाँ चढ़ जाओ सर Thank you. So wait. Prahlad, thank you. Prahlad, thank you for all the things. Thanks. बहुत अच्छा था, बहुत मजा आया हम लोगों को. Thank you. उनके लिए तालियां बनती है जो हमको लास्ट 3 डेज से खाना खिला रहे अच्छे से. Okay. And cameraman, जल्दी फोकस करो. Thank you for these wonderful pictures. आपको भी नाम नहीं पता है बस, सॉरी, थैंक यू फॉर ऑल दिस वंडरफुल पिक्चर्स. ऑल आर ट्रेड पार्टनर्स, ऑल आर साइंटिफिक पार्टनर्स, आर प्लेटिनम स्पॉन्सर्ड. रजानी सर कहाँ गए? चल गए. थैंक यू सर फॉर सपोर्टिंग मेडिमेट सिंस लास्ट 10 years. Neon Laboratories and Heart and Vascular Super HUS Hospital, and our MOC for chair partner last 5 years, 7 years. MOC chair covers last 5 years. Our gift partner Glennon Healthcare for all this wonderful arrangement. I'll request all committee members. क्या करना है? हो गया ना, चलो अभी जाएंगे कैसे? Okay, so we'll go for our bumper draw. I'll request to please. Bana pachi. Okay, so we'll have 1, 2, 3 and 2, 5. Three gifts है वहाँ पे. और आपके पॉकेट में कितने कॉइन है? 2 कॉइन, दोनों गोल्ड है. कितने ईमानदार 2 बोल रहे हैं ना?
लेके जाना है कि देना है?
देना है भाई, देना है. So किसको गोल्ड कॉइन नहीं मिला है? सबको मिला है गोल्ड कॉइन, सबको गोल्ड कॉइन मिला. हाथ किसी का भी ऊपर नहीं हुआ है. सबको गोल्ड कॉइन मिला है. तो मैंने क्या क्वेश्चन पूछा? किसको गोल्ड कॉइन नहीं मिला है? हाँ तो रेज योर हैंड ना. तो सर के पास पॉकेट में बहुत सारे हैं.
किसको गिफ्ट, कोई भी गिफ्ट नहीं?
हाँ अच्छा चलो, किसी को एक भी गिफ्ट नहीं मिला है. ओ शिट, तो गिफ्ट गया किधर? इतने सारे कल से गिफ्ट बांटे जा रहे हैं हम लोग. तो नेक्स्ट टाइम रखेंगे कि जिसको गिफ्ट मिला है ना, नेक्स्ट टाइम कूपन नहीं डाल सकता है. ऐसा कुछ रखेंगे प्रोविजन हम लोग. राइट, ओके, सो विल स्टार्ट. चूज मी मैम. चलो फर्स्ट गिफ्ट कमिंग अप इज, क्या है ऊपर वाला? धारणा कॉफी मेकर गोज टू डॉक्टर बसंत जैन. है सर? अरे ये लो, टेबल पे कुछ तो कुंडली मारा है क्या? लिम्बी में मारेगा टेबल के ऊपर. लाओ प्लीज. नेक्स्ट कौन बाकी? हाथ दिखा इधर आ. एक निकाल अच्छे से नाम. मेरा नाम निकालना चाहिए पहले, बता रहा हूँ. हाँ तो मुझे नहीं पता है. सेंटर. कोई भी बाहर जाएगा नहीं, बिकॉज मुझे यहाँ पे हम सबका एक साथ में अच्छा सा ग्रुप फोटो चाहिए. ओके, उसके बाद यू ऑल कैन गो फॉर अ लंच एंड देन वी मीट फॉर नियर द बस. ओके, नेक्स्ट इज हॉट प्लेट वैक्यूम क्लीनर. क्या वैक्यूम करे, किधर क्लीनिंग करेगा? ले सारी का. हाँ रुको, पता है 2 बाकी है, 2 गिफ्ट बाकी. डॉक्टर गिरीश त्रिवेदी सर है? नहीं इधर है, उसे निकालिए. डॉक्टर DM पटेल. हाँ 6 भाई क्या रहा है? वैक्यूम क्लीनर. लास्ट क्या बचा वहां पे? रुको, अभी वो साइड पे इंडक्शन. हाँ ये बड़ा है बहुत. उसका डॉक्टर प्रीतेश आप निकाल देंगे. ये गिफ्ट. ओ डॉक्टर प्रीतेश गोगरी का नाम आया इसके अंदर. डॉक्टर प्रीतेश गोगरी है. ये चाहिए इंडक्शन कॉइल. प्रीतेश का नाम है इसके अंदर. प्रीतेश पे खाना बना. ओके, द गिफ्ट गोज टू डॉक्टर अशोक विशावाड़िया. अशोक सर 6 चमन लाइगुज देखा है नहीं सर? प्लीज सर कम. ये सर आपको कल मिला था? हो गया. तो मतलब ऐसा है ना कि तो नेक्स्ट टाइम मैं बैन ही करने वाला, एक ही बार कूपन डालने का. पर नहीं सर, इट इज लक फैक्टर. प्लीज सर. वाइफ के साथ आए बोलते हैं. मैम चलेगा ऐसा क्या? चलो प्लीज सर. ये मेरा है. चलो क्या किसका बाकी है? अभी इसमें गिन के 5 कूपन है, बाकी सब गए किधर पता नहीं. ओके, सिल्वर कॉइन बाय BMB. सर जी आप ही निकालो, जवाबदारी आपकी. हमारा नाम आया तो बरोबर ना सर? हमारा भी नाम आ सकता है. करते। अरे मैं बोला परेश मेहता से निकला अंदर से। उधर नींबू मारा है तुम लोगों ने।
The last benchers again so much lucky. Dr. Kalpesh Dave.
बोल रहा हूँ उधर नींबू मिर्ची मारा है वो टेबल के ऊपर। कल से उधर ही बैठो सब लोग। फाइव था तो क्या हाँ सिल्वर। हाँ तो वही सिल्वर ही है। नो वी डोंट गिव गोल्ड। नहीं ना ऐसा कैसा, सिल्वर महंगा है सर गोल्ड से अभी एज ऑफ नाउ। चांदी चांदी है। ओके कमेटी मेंबर का लेके आओ आप ही। ओके नेक्स्ट द गोल्ड कॉइन। 10,000 15 15 20 प्लेटिनम स्पॉन्सर लास्ट लेवल का डायरेक्ट और बनना सर। नाउ गोल्ड कॉइन। हाँ सर आप सर सेटिंग कर रहे हैं ना।
चिराग जोशी।
ओ वाह क्या ऑब्जर्वेशन है पार्टी का। ओके अभी तुम लोग को भी चाहिए सर, सवाल ही नहीं है। ओके सो विल हैव वन स्मॉल लकी ड्रॉ एज वेल फॉर आवर कमिटी मेंबर्स एज वेल बिकॉज उन्होंने आपके बॉक्स में नहीं डाला है। ओके सो विल हैव फॉर देम एज वेल। चल हो गया पार्टी। आज નાખી છે વખતે આખે બધા સ્કોપ વધી કાજલ નથી ને બધા સ્કોપ વધી ગયા છે। सबके चांसेस बढ़ गए। मनोज ऐसे हो जाए, मनोज है, मनोज तेरा नाम है इसके अंदर तो कमेटी मेंबर ने आधा। कौन निकाले कौन निकाले कौन निकाले जवाबदारी लेगा कौन ना। हाँ नमन सर इधर आओ। निकालो उसमें से एक कॉइन। कॉइन तो निकाला पा नाम निकाल।
देखिए ये बेचारे आस लगा के खड़े कब से, ठीक है इनको कुछ नहीं मिलने वाला है, सब चिट्ठी पे मेरा नाम है। लगा ही था। मैंने सिर्फ सरनेम पढ़ा है। नहीं 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 जेन्युइनली कोई मिस्टर पारेख है यहाँ पर? धारणा पारेख
प्लीज। थैंक यू everyone please join everyone please join। इन्होंने वापरे की किधर बैठे हो तो बता। मनोज पे जरा मनोज तेरा ही लॉस हो रहा है रे। ओके विल हैव वन ग्रुप फोटो टू प्लीज एनीथिंग। ओके सो बिफोर वी हैव अ ग्रुप फोटो आई रिक्वेस्ट प्रेसिडेंट सर टू कंक्लूड आवर मेडिमिट 2026 11th साइंटिफिक कॉन्फ्रेंस। सर भाई તમારું રેડી છે આશીષ સર શું કરું છે ચાલશે બતાવી દો હા પણ ટિપ તો આપી દો એક ચાલો હું ખાલી વાત 2 મિનિટ એઆઈ ટિપ્સ ભાઈ આશીષ એઆઈ ટિપ આપે છે એઆઈ ભાઈ એઆઈ
ओके अभी
माइक
so 5 minutes I will just give some 1 or 2 AI tips. So there are two tips that I'm going to give you all. One is how to book the cheapest flight tickets and the second one is how to buy any product the cheapest on Amazon and all these other websites that we buy. Okay, so सबसे पहला चीज़ है flight booking के लिए. So whenever you all are trying to search for a cheap flight ticket तो इनकॉग्निटो मोड में जाने का क्रोम में और उधर फ्लाइट के लिए डेस्टिनेशंस डाल के ढूंढो। अगर तुम नॉर्मल मोड पे जाओगे सो वहाँ पे एल्गोरिदम ऐसा है कि सेकेंड टाइम सर्च करोगे तो 1000 रुपया टिकट का भाव बढ़ जाएगा। You will not get the cheapest flight ticket because the algorithm is set in such a way that automatically they come to know that you want to fly this route और तुमको वो ticket महंगा मिलेगा जो normal से है वो. This is the way the flight people earn the money. So whenever you are searching for a flight ticket, go into Chrome, start incognito mode, then you search for your flight ticket. ठीक है? So एक बार तुमने search कर लिया तुमको कौन सा flight लेने का है. So the next thing to do is to go to Skyscanner. Skyscanner is the app which has got the cheapest fares. Ixigo में भी उतना cheap नहीं है, GoIBIBO में भी cheap नहीं है, but Skyscanner में सबसे cheapest fares है. So and a lot of flights are there which they are not listed by priority, but those things are listed on Skyscanner. तो Skyscanner में जाओ और flights देखो. उसके बाद में flights देखने के बाद में whenever you all want to buy the ticket, so there is a credit card which is available from ICICI Bank also, or it is called as Amazon credit card. Okay, so Amazon credit card कैसा है, उसका limit है 20,000 रुपये का या 30,000 maximum you can have that much limit. तो वो कार्ड से कुछ भी तुम खरीदोगे तो तुमको 5% कैशबैक मिलेगा, तो तुम्हारा 5% और फ्लाइट टिकट कम हो गया. उसके बाद यू रजिस्टर योर सेल्फ फॉर माइल्स. ओके, तो माइल्स मतलब इंडिगो का माइल्स है, एयर इंडिया का माइल्स है, सबका माइल्स है. तो जितना पैसा तुम स्पेंड करके टिकट लेते हो तो वो टिकट पे तुम्हारा माइल्स ऐड होता है. जैसे जैसे माइल्स ऐड होता है वो पैसे की तरह बनता है ऐड, और वो नेक्स्ट फ्लाइट के लिए आप उसमें और कंसेशन ले सकते हो. सो क्रेडिट कार्ड से कंसेशन मिल रहा है, फ्लाइंग माइल्स से कंसेशन मिल रहा है, प्लस स्काई स्कैनर ऐप का कंसेशन मिल रहा है. सो 3 कंसेशंस यू विल गेट व्हेन यू आर ट्राइंग टू बुक योर फ्लाइट टिकट्स. एंड द मोस्ट इम्पॉर्टेंट, तुम्हारे बैग पे एक स्टिकर लगा हुआ रहता है फ्लाइट में. हमेशा वो स्टिकर जब भी तुम निकल, दैट स्टिकर अगर मैं स्कैन करूँ, इट हैज़ गॉट एवरी पॉसिबल इंफॉर्मेशन अबाउट यू. तो हम लोग कोई वो स्टिकर ठीक से फाड़ के नहीं फेंकते हैं, हम लोग ऐसे ही फेंक देते हैं. वी कैन हैव अ लॉट ऑफ इन्फॉर्मेशन विच वॉट एवर इन्फॉर्मेशन यू हैव गिवन टू द फ्लाइट पीपल, वो सब इन्फॉर्मेशन वहाँ के QR कोड में है. तो वो स्टिकर अच्छी तरह से QR कोड फाड़ो और फिर फेंको, ऐसे ही मत फेंको व्हेन यू कम होम. ऑलराइट, सो दैट वाज द फर्स्ट टिप फॉर द फ्लाइट. द सेकेंड वन इज हाउ टू बाय द प्रोडक्ट्स द चीपेस्ट. समझो अभी मुझे एक फ़ोन खरीदना है. ऑलराइट, सो द फर्स्ट थिंग दैट आई हैव टू डू इज गो टू अ साइट कॉल्ड productchart.com. गो टू productchart.com. उसमें तुमको एक अच्छी तरह से कंपैरिजन मिल जाएगा. तुमको कितना GB का फ़ोन लेना है, 512 GB है या कितना रैम है, कौन सा कंपनी है. सो एक बार वहाँ पे जाओ, प्रोडक्ट चार्ट पे जाके डिसाइड करो व्हाट फ़ोन यू वांट टू बाय. ओके, सेकंड व्हाट यू हैव टू डू इज क्रोम पे जाओ और सर्फ करो. एक बार आप सर्फ करोगे ना, 15 मिनट के बाद में फेसबुक या इंस्टाग्राम खोलोगे, सब एडवर्टाइजमेंट्स चालू हो जाएगा उसके ऊपर. तो आपको इमीडिएटली पता चल जाएगा कि आप यहाँ से फ़ोन लो, यहाँ से फ़ोन लो. बहुत सारे साइट्स आने चालू हो जाएंगे किधर से आपको वो फ़ोन लेना है. ऑलराइट, सो वंस यू डिसाइड विच साइट यू वांट टू बाय, ऑलराइट, यू मे हैव सम साइट्स विच आर much cheaper than the original ones. So go to that site, see what is the site about. Okay, आफ्टर दैट एक बार वो साइट का देख लिया, फिर वो साइट को डालना है cutestats.com. इफ इट इज सम न्यू साइट, go to cutestats.com, find out about the reviews of that and after that you will come to know कि ये genuine website है, इसके ऊपर हम पैसा खर्चा कर सकते हैं, हमको fraud नहीं बनाएगा. So after cutestats.com go to pricecompare.com. pricecompare.com बताएगा आपको कि और कोई साइट्स है जिधर ये प्रोडक्ट तुमको और भी सस्ता मिल सकता है. सो इट विल कंपेयर प्राइसेस ऑफ मिंत्रा, अमेजॉन, फ्लिपकार्ट, वही प्रोडक्ट हर जगह पे सबसे सस्ता किधर है वो आपको मिलेगा. उसके बाद में आप कार्ट में डालो, पुट इट इन द कार्ट. समझो तुमको पता चला ये सबसे चीपेस्ट अमेजॉन पे है, तुम कार्ट में डालो और फिर कुछ मत करो. आप खाली 10 दिन रुको, 10 दिन खाली रुकोगे ना, सामने से डिस्काउंट कूपन आने का चालू हो जाएगा आपके ईमेल पे. सो डिस्काउंट कूपन्स 5% डिस्काउंट, 10% कूपन्स आते हैं. डिस्काउंट कूपन्स अप्लाई करो, बाद में वो प्रोडक्ट को खरीदो, और जब भी खरीदोगे अमेजॉन के कार्ड से खरीदो, वापस तुमको 5% कैशबैक मिलेगा. So that is the way to buy a product. So you can save money. See, now you have to be smart when you are buying things. So flight में भी तुम पैसा बचा सकते हो ऐसे ही, वैसे ही प्रोडक्ट में भी तुम पैसा बचा सकते हो. All right? Thank you.
Thank you. Very informative.
Final, Parashmita sir.
So I hope you have really enjoyed this MEDIMEET. When we started, means every year, whenever we start with planning of the MEDIMEET, the first and formal meeting, भले ज़रूरत नहीं है, तो भी हम लोग मीटिंग करते हैं राजानी सर के साथ में, और सर पहले से बोल देते हैं कि यू डोंट वरी, आई एम विथ यू. देन ऑल्सो एक बैकिंग मिल जाता है. सो अगर आपको ये MEDIMEET, इफ़ यू हैव एंजॉयड दिस इज ओनली एंड ओनली बिकॉज ऑफ यू मेंबर्स डेलीगेट्स. तो एक बार जोर से तालियां बजनी चाहिए आपके लिए. आप आते रहिए, एंजॉय करते रहिए, और MEDIMEET में BMB का नाम ऊपर आते रहेगा. थैंक यू सो मच.
Okay, requesting everyone to please join so that we can have a beautiful group photo. एक पार्ट पीछे पीछे जाके पूरा साथ में फोटो ले लीजिए, पूरे ग्रुप का. सब लोग यहाँ पे, ये लोग यहाँ पे आएंगे, आप वो साइड चले जाइए. नहीं, ग्रुप में कोई रैंडम फोटो चाहिए, फॉर्मल नहीं लगना चाहिए कुछ भी. फॉर्मल थिंग सब खत्म हो गए, कंक्लूड हो गया, अभी सब इनफॉर्मल्स है. चलो तेजू, कम.